What is life without a little levity? All right, the 10th meeting of the Community Vaccine Advisory Committee. And once again, we're really grateful to all of you for making the time in your very, very busy schedules to participate in this process. And I think we have a great meeting ahead. And so we will dive into it. I want to, if we can jump into the first slide. For today's meeting, Dr. Erica Pan, my esteemed co-chair, is doing some very well-needed self-care today. So she is out with her family on a little vacation. And so Dr. Tomás Aragon, our state public health officer and director of the California Department of Public Health, will be my co-chair for this meeting. And we're very grateful for Dr. Aragon to stepping in that role and participating throughout the meeting, representing CDPH. And Bobby, if we can have you do the logistics and walk through kind of the meeting basics, that'd be wonderful. Thank you.
Great, thank you. Hi, everyone. Thanks again for joining. Instead of the 100th meeting, it's maybe the 100th hour and the 10th meeting. So welcome, everyone. Again, just as a reminder to the members of the Community Vaccine Advisory Committee, it's great if you can leave your cameras on and your microphones on mute until you're ready to speak. And I think everyone is well versed in the hand raise icon to make comments or ask questions. So thank you for using that. We're pleased to welcome again our Asl Interpreters, Katie Sales and Vicki Kennedy, who you can see spotlighted on your screen. And just a reminder to members of the public, we have listening in both in English and Spanish on a listen-in only phone line. And also we are live streaming the entire meeting on YouTube. Those of you that would like to make public comment, you may submit public comment at COVID-19 vaccine outreach at cdph.ca.gov, which you can see here on the screen. If anyone has any technical difficulties during the Zoom, any of the members, if you can put your questions that are of technical nature also in the chat, we'll be happy to see if we can help you during the meeting. I think that takes care of the meeting logistics, Dr. Burke-Harris.
Thank you, Bobby. And well, why don't we go ahead and hear public comments from since the last meeting?
Great, thank you. So just as a reminder to all of the members and the members of the public that are listening in, on the Monday evening before our meeting, we close off the public comment so it can be compiled and it is sent out in its complete form to the members of the Community Vaccine Advisory Committee so that they can review the public comment before the meeting. So the public comment for this meeting covers the period February 2nd to February 15th. We had over 80 pages of public comment, including a number of links to several hundred additional pages of attachments. 351 individuals and organizations made comments, and each or many of the comments had multiple issues that they wanted to address. So let me summarize the issues that were submitted as part of public comment. We had 39 people who asked that the whole process of getting a vaccine, finding out where to get a vaccine, the tiers and phases be simplified, that there be clarification of the process to sign up for a vaccine, including how to use the My Turn app that CDPH and the governor's office have created, a way to understand what the reliable forecast of vaccines would be, flexibility on the tiers, and consistent rules across counties, with a number of examples given of how one group in one county was called for vaccines, but another group in another county was called for vaccines. We had many people asking to be prioritized higher in the process than they currently are, including comments by 57 individuals that people who are homeless and employees who work with the homeless, not by age, be categorized in Tier 1A, that frontline workers be prioritized and given vaccines, that people working in animal shelters and zoos be lifted up higher in the priority list, that school staff and teachers be prioritized, and also that appointments be made available not during school hours. Cosmetologists and barbers asked to be prioritized higher up. Public transit workers, we heard from 20 individual public transit authorities asking for their employees to be prioritized. The Chief Justice of California's courts wrote again for the second time asking that all judicial and court employees be prioritized. We heard from one local government asking that all of their employees, including their law enforcement staff, be prioritized. We heard from the logistics and manufacturing industry, from the community services districts. We also heard from 48 individuals who had themselves or relatives with underlying medical conditions under the age of 65, including these conditions that I'll read off, that they be started to be vaccinated sooner than March 15th, including diabetes type 1, all types of cancers, people living with HIV and AIDS, people with autoimmune conditions, paralysis, developmental disabilities, Parkinson's disease, cystic fibrosis, schizophrenia, and all types of kidney disease. We heard from the cannabis industry that they be prioritized as part of the agricultural workers. We heard from the dock and port workers. We heard from a retirement community that wanted to be vaccinated as a congregate living facility. And we also heard from 183 individuals and organizations requesting that immigrants in detention facilities and others that are incarcerated be vaccinated immediately. We heard from an acupuncturist organization offering to assist giving vaccines since they use needles so often. We heard from one individual asking that the second shots of the vaccine, the second doses of the 2-dose vaccines be delayed so that more people could get the first dose. We had 3 public comments raising questions about the choice of Blue Shield as the TPA. We heard from 2 individuals identifying that community health centers are should be primary vaccine sites, particularly to ensure equity. We heard from one individual who was charged $71.38 by her healthcare provider in order for her to receive a vaccine. And we also heard from a number of groups who wanted to join CVAC, including representatives of the airline flight attendants, fat people, disability justice, the Commission on Aging, as well as the request for 2 representatives of the Native Hawaiians and Alaskan Natives to be asked to join the Community Vaccine Advisory Committee. And that is a very short summary of many very passionate public comments that we received this week. Thank you.
Thank you so much, Bobby, for summarizing the public comment. And thank you to the members of the public who took the time to share their important perspectives with us. The public comments have been shared with all of the members of the CVAC. So you all should have that. And I want to encourage you to read all of the public comments because they are very passionately written. And now as we move into the meeting, I want to, with every meeting, I feel like it's important to, again, ground in the values that bring us to this work of safety, equity, and transparency as really the bedrock that we walk into, that we come into this meeting with. And I also want to remind members of this body that as we think about the purpose of this committee, we've been very grateful to have lots of excellent feedback from all of you, in addition to the feedback that we're getting from the members of the public. But in addition, for all of you, we hope that you will be carrying forward the information, the resources, the insights into deliberations that you all are hearing during this meeting back to your the communities that you represent. And so we want to just really hold that bidirectionality of this process, where we as an administration are sharing with all of you, and then hopefully and certainly we are hearing all of the wonderful insights and information that you have to share with us from your constituencies. And in particular, today, I'll talk a little bit about the agenda in a moment, but today we'll be talking about the My Turn system, and we'll have the opportunity for a demonstration of the My Turn system. And so we're hoping at the, you'll have an opportunity to have lots of questions answered, ask our teams. And then at the end of this process, hopefully talk to the communities that you represent about going on to My Turn and either making an appointment if they're eligible, or registering so that they can be updated and informed as to when they would become eligible. And now I'd love to invite Dr. Aragon to make a few remarks before we dive into the agenda.
Good afternoon, everyone. Thank you for spending time with us this afternoon. I want to just give a little bit of an update, just to let you know that in terms of the COVID infections across the state, that things continue to get better. In the last 24-hour period, we only had 4,090 new cases that were reported. The effective reproductive number is down to 0.65 for the state. That's the lowest I've seen it. I can't remember when I've seen an R effective down that low. And so that's really good news. Our 7-day case rate is down to 20, and our percent positivity is down to 3.3. So we're moving in the right direction. The reason why this is important is that as this improves, that means the average risk goes down. I'm going to assume that the vaccinations is contributing to this, and just hopefully this will continue to move in that direction, because it means that over time, all of us are a little bit more safer as this improves. And so all the mitigation strategies that everyone does across California, physical distancing, wearing your face covering, moving things outdoors, is making a big difference. And you'll see the state health department and the state in general is going to be re-emphasizing how important it is for us to continue to do this as we're in this transition period to eventually coming to community immunity. So that's all I want to say, and I'll turn it back to Dr. Burke-Harris. Thank you.
Thank you so much, Dr. Aragon. And so for today's meeting, it's always, can I just say that it feels nice to start with a little bit of good news. And for those who are not familiar with the term R effective, when Dr. Aragon says that R effective is down to 0.65, it means that each individual who is infected infects X many people, right? And so if the R effective is above 1, it means that more and more people are getting infected. And the idea that each person who's infected is infecting essentially 2/3 of a person, right? That's each 3 people who are infected only infect 2 people. That's really good news in terms of reducing the spread and stopping the surge. So that's that is what makes us feel good when we get up in the morning. So thank you so much for that, Dr. Aragon. So today, for today's meeting, we are going to talk about, we're going to start by hearing next steps on community engagement, equity, and vaccine acceptability or confidence. We're going to continue the discussion that we've been having with the governor's office and the Department of Social Services and the Department of Public Health. We'll also hear an update on vaccine supply and distribution from Dr. Aragon, as well as many of you know that our third-party administrator agreement was executed. So we will have Secretary Yolanda Richardson, who's the Secretary of Government Operations, will join us today in our meeting to answer your questions on the TPA. All of you should have received a link. The TPA contract is out there on OpenGov. So all of the members of the committee should have received a link to that TPA contract. So Secretary Richardson is here to answer any questions. As I mentioned, we will have a demonstration of the My Turn system. So all of you can see, exactly how does it work to sign up to on My Turn to be notified when you're eligible for vaccine. And we hope we'll share that information with your constituents. And then finally, we will hear some updates on the recommendations that were released last week pertaining to individuals with underlying medical conditions and people with disabilities. I know that's certainly been a hot topic in this conversation. Thank you to everyone who has contributed to that conversation and who is in the process of helping us be more effective in responding to the needs of individuals with pre-existing conditions that increase their risk for severe COVID disease, as well as certain disabilities. And so as we go through that agenda, we will work hard to get all of your questions answered. But there are two topics that I wanted to speak to before we dive into the agenda, as we don't have someone to speak on that today. We didn't want to have too crowded of an agenda. And the first is one that we heard that has been raised by this body and also has been a question in the public comments. And that is the question about how individuals in federal immigrant detention centers are being vaccinated, or what is the plan for them? And this question was raised in this meeting by this body. And so as is our commitment to you, we took that back to find the answer. And I will tell you very transparently right now, the answer right now is I don't know. I will say that there are some, I now understand it's been a little bit of an education that, that while we recognize very much that you all want to know the answer and are working to try to find out, there are some real complex jurisdictional issues that are at play. And so for today, I don't have an answer for you. So I wanted to speak to that and be very transparent about that issue. The second question that I wanted to speak to was this question of, are we using HPI or are we using are we using census tracts or are we using zip codes when we are talking about applying an equity tool using HPI, using the Healthy Places Index? And the answer to that question is that we are still in the process of doing the modeling to assess the impact of doing each. And we're also trying to get input from entities and particularly vaccinators on how that would impact execution, right? How that would impact implementation if we were using zip code versus census tract. Sure. So the short answer to that question is that we're still in process, and we'd love to as we are reaching out to vaccinators and others to understand the impact of this decision, we'd also love to hear from you. Please feel free to share in the chat, or lots of folks have been sending us resources in terms of any impacts or concerns that you have in terms of using zip code versus census tract. And now with that, I would like to reintroduce our team who is leading the community engagement and equity part of the agenda. That is Marisela Rodriguez, who is the Director of Civic Engagement and Strategic Partnerships in the Office of the Governor, as well as Martha Dominguez, the Senior Communications Advisor for CDPH, and Marcela Ruiz, the Director of the Office of Equity for the California Department of Social Services. Marisela, do you want to take it away? And Marisela, if you are speaking, we can't hear you, so you may be on mute.
I don't see Marisela on the Zoom. Marcela or Martha, do you know if she's been held up?
I'm going to text her real quick while we see if she joins us in a second.
Okay. And Martha, maybe you want to go ahead and start? Would you like to do that?
Yes, I can. Sorry, I was trying to text and multitask at the same time. It's okay. I'm happy to go next while we wait for Marisela, if you don't mind scrolling through my slides.
Yeah. Let's go to slide 10. Yeah.
Okay.
There we go.
Well, good afternoon, team and committee members. I thank you for allowing me to be here again. Wanted to kind of give you guys an update. As I have been sharing the last couple of meetings, I've been sharing some research findings. I've also been indicating to you that we brought on a new team, a multicultural media agency, Duncan Shannon, along with some other key partners, Baru, and also a partnership, also Nuna Consulting Group. They're helping us to ensure that our messaging reaches our communities. Next slide, please. With that said, I wanted to give you guys sort of next steps on our communication strategy based on the research that we have done in the last month or so. We are working on a strategy that is embedded on the education, motivation, and activation, and these will happen simultaneously. We have a paid media campaign right now that has really underscoring some key messages about vaccine safety and reminding people to wear a mask, et cetera. But as of March 15th, we will be launching new creative. And when we say launching new creative, meaning derivatives in terms of our research, it's creative that our new multicultural media agency has put together that will be targeted, again, from a very multicultural buy, reaching our diverse communities. We will also be building a public relations strategy focused on key audiences, and this is going to be done specifically through earned media and also through social, and also really engaging communities on the ground and local health departments at the local level. As we all know, we're focusing on key audiences such as healthcare workers, 65 or over, farm workers, to call out Latinos, African Americans, Pacific Islanders. And all of this communication strategy is informed based on our formative research, creative testing, sentimental analysis. We're also doing some mis and disinformation monitoring, and it's also based on the eligibility phases operations of California. Next slide. I did want to take a moment and really share with you guys a little bit more specifically on our messaging. This is really our communication strategy. And this messaging is really 4 pillars that are intended to happen all at once. They're not intended as phases. That's because together they're more impactful than anyone on their own. The pillars are not mutually exclusive. Each pillar objective is meant to define primary objectives for anyone given the tactic or channel. At the same time that we are, releasing information. So we want to make sure, for example, if a TV ad's primary objective is to connect emotionally, but it may also provide some additional education. So that is the strategic approach that we are wanting to really implement as we move forward with the campaign. Another example would be having an influencer engagement like on social media or digitally, primarily is to help us normalize the information and elongate any education, but may also connect an emotional empathy way with the audience. These 4 pillars are really critical in our campaign. They're based on research, and we will continually to do what we call quality assurance and improvement to ensure that these pillars are moving the campaign and are moving the needle in a very culturally congruent manner to ensure that we reach all Californians. More specifically, we have the connect, educate, normalize, and activate. These are very strategically put together. There's also intention on what media channels or platforms we will be utilizing to ensure that we elongate the messages. So we wanted to be very transparent on our communication strategy with you and really start to connect where the rubber hits the road in terms of the research and really the communication strategy. So that's really at a really high level, the next phases of our campaign, but we wanted to make sure that we shared our approach as we move forward on execution of the campaign. With that said, this concludes my part, but I am happy to punt it over to Marcela.
Yeah, I think we have Maricela with us, Marcela. So would you like Maricela to go first?
I think, Bobby, I'll go next. This is Marcela.
Okay,
And Maricela will close this out today. Thank you for accommodating, and good afternoon, everyone. It's really great. It's really great to be on and to see the names and the cameras on, and to see again so many of you. Next slide, please. Today, we are just providing a very brief update on the community engagement campaign funded through CDSS and Labor Workforce Development Agency. In the next meeting, we expect to go in a little bit deeper into the specifics of the effort. So just by way of update, we have been providing you with information about the timeline for the campaign. The last time we joined you, we let you know that we would be announcing the subcontractors through the center at Sierra Health. That list of contractors is now available, and I'll show you in just a moment just all the organizations who were selected. But we did announce awards of $17.3 million through both Labor Workforce Development Agency and CDSS to 110 organizations throughout the state. Since that time, all of those selected partners have been engaged in a very, very robust schedule of onboarding, where they are receiving information and training from different state partners around the overall public health situation in the state, vaccine updates, state resources available for people who may have economic needs as a result of COVID, as well as opportunities to learn from their peers. There's a lot of best practices, right, that you have all developed. Our CBO partners who are on the line today have all developed during these times of COVID, and it's been also great to hear those experiences from partners as we plan the outreach events is still in this COVID world. That onboarding will close off on Friday, and our outreach partners through the Center at Sierra Health will begin their outreach next week. And so in the next couple of weeks, we expect to come back and share with you a little bit more about their activities. As we mentioned, CDSS is, in addition to working with the Center at Sierra Health, we have another really terrific partner in the California Community Foundation. The California Community Foundation, like the Center at Sierra Health, was a critical partner during the census. And as we've said multiple times, we are using a lot of the infrastructure and the lessons learned from the very effective census campaigns. They are on track to announce their partners, their awardees, probably next week. We expect that our philanthropic partners will also announce the organizations they have selected through the administration of the Public Health Institute to conduct the outreach. So definitely a lot more to come in the coming week. And if we could see the next slide, please. What you are seeing right now on the screen is a very, very tiny print, because this is the large group of partners who are part of the CDSS cohort. And just again, by way of reminder, CDSS is working collaboratively with Labor and Workforce Development Agency to administer this funding. We have a lot of joint infrastructure. We have a lot of joint reporting. We wanted to do that in order to reduce the administrative burden out in the field. We didn't want to replicate, or we wanted to be aligned around some of the reporting and some of the requirements, right? Because we know that you also are being funded by other sources, and we realize the administrative burden that can create. So what you're seeing on screen right now are the partners for the Department of Social Services. The Department of Social Services campaign is primarily focused on the public health message, as well as connecting individuals with resources to address economic needs. We will be focused on referring people to the My Turn platform. We will be focused on addressing vaccine hesitancy, and we will be focused on connecting people with resources. Next slide, please.
Big butt.
And this is the Labor Workforce Development Agency cohort. Hopefully many of you can see the names of your organizations up on the screen right now. The Labor Workforce Development Agency cohort is a little bit more focused on the labor rights. As we know, there have been new protections that have been signed into law specifically associated with COVID, in addition to the already existing labor laws that protect workers. However, as you all know, we expect that CDSS funded organizations will also encounter workers, right? You can't separate out people into those categories. We are focused on vulnerable populations, including Black, African American, Latinx, NHPI, Native American populations, but many of those populations are also workers. So we will be carrying joint messaging across both of those campaigns, in recognition that people will need the resources that CDSS and LWDA are both able to provide. And with that, I will hand it over to Maricela. And as I mentioned, in a couple of weeks, we will have more information from the partners who are conducting outreach.
Great, thank you so much. Appreciate that. We can go on to the next slide. So just wanted to give you a quick, some highlights, similar as we've done in the past, just giving you some quick highlights on what we have going on. For the first one, and mentioned in the last presentation, we do have some activations specifically targeted to the African American and Black community, and that included our community champions efforts focused on Black History Month. We do have work happening through radio, print, and social media that's going to run for a couple weeks. Wanted to highlight the hashtag because it is an activation. There is an activation component to this. And so if you have a community champion you would like to highlight that's on the front lines of our COVID-19 response or helping to get out a vaccine, education efforts, you can nominate yours. It's very much a social media activation. So use the hashtag, highlight someone that you care about and want to give credit to. And then we do have a town hall that's specifically focused on engaging community. And we have our Surgeon General who's going to help present on that along, and it's being done with in partnership with Charles Drew University, and having a couple of other experts and trusted messengers that are going to help lead the conversation, covering issues around misdis, what's sort of the latest with the state, and providing some key facts, as we've talked about in the past, that are really important to get out right now with the community. Also specifically focused on the Black and African American community. And then had mentioned also that we were also going to continue to do a second round, in some cases a first round of ethnic media briefings. And someone may not be on mute, just noting that. So we have them starting February 22nd through the first week of March, and can follow up in our next meeting with some updates on how those went. We do have, as you can see, working in partnership with ethnic media, including NUNA, California Black Media, and Ethnic Media Services. And then just a quick update, along with our ethnic media briefings, we're doing direct pitching, other efforts around earned media, and collectively, and I think we're almost at a daily cadence now, have now gathered around 360 stories in multiple languages, really trying to be very consistent with providing up-to-date information to the community in language through trusted messengers. So really happy to see that work continue, and working alongside our ethnic media partners. Next slide, please. And then wanted to show you our latest PSA. I believe I may have hinted at that at the last presentation. This is, and I'll have Bobby's help in a minute to help play it, but just want to give you some background on it for our just overall efforts around COVID-19, and encouraging folks on, especially when we had, our incredible surge in December, had a PSA that ran, having mothers encourage their children to stay home, waiting to see loved ones, just because that keeps folks safe, especially in a moment where we had the surge. And now we're seeing our numbers stabilize through the many efforts that folks are doing collectively. And this is took the same concept and now applying it to vaccines, because we know mothers carry a very important role in family, an important voice in community. No one can deliver a message like mothers. And so whereas before we were giving folks a reason why they should stay home to keep each other safe and protect each other, now they're lending their voices to why they should get vaccinated. And wanted to go ahead and play first the English and then the Spanish.
Like seeing my mom. It's unthinkable to me that I can't see her and I can't hug her.
Not being able to hug is just like somebody has to tie me down.
Touching someone to say, I love you, to hug you, those are the things that I miss.
El abrazar a mi mamá, el ver a mis hermanos. Yo nunca había pasado tanto tiempo sin mi mamá.
Cuando me dicen te amo y me dicen Mima, Mima te amo.
No poder compartir con los amigos.
Cuando veo a mis nietos y no los puedo abrazar, ay.
Great. Thank you, Bobby. And you know, this really kind of covers some of the learnings that we've shared in the past that Martha has shared, the use of, you know, real people, real voices, making it very personal, and you know, the real desire for families to, you know, return to normalcy, which includes being together. So I'm really happy with how these PSAs came out. We want to continue to do more of this work with Martha's help. So looking forward to continuing to share our work as we move forward in executing the strategy that she helped laid out earlier. So I'll go ahead and turn it back to you.
Well, I am reading the chat, and I have to say thank you to our committee members for this positive feedback. I'm seeing lots of great job, well done, beautiful videos, and I really want to congratulate our teams for your really excellent work. And it sounds like that is appreciated by all. I want to open up to see if there are any questions.
Okay, so let's get started here. I think before I call on Matt and Denny, you'll be first, but I want to ask Diana put a question in the chat early on about outreach workers getting vaccinated. Diana, why don't you ask your question and make sure to introduce yourself, and then we'll go to Matt and then Denny.
Sure. Thank you, Bobby. Diana Tolosan Torres, Executive Director of the UFW Foundation. We're getting that question on the ground from staff for sure, and also from other partner organizations asking whether those organizations who are directly contracting with the state will be able, and the intermediaries, of course, will be able to have their outreach staff vaccinated, and how that process could look like on the ground. I know that we've directly asked different folks on the ground, and I know the question has come up from Maria Lemu regarding promotoras and others who are on the ground being able to get this protection. So just advocating to make sure that that's happening on the ground so we can also feel safer, especially since many folks are out speaking with farm workers and other vulnerable communities. It's just something that would make us feel much better. Thank you.
Thank you, Diana. I will tell you that my short answer is I'm not sure. Dr. Aragon, do you happen to know the answer to that question?
Yeah, only if it meets part of the current prioritization guidelines. And I don't think that that's going to be the case with what you just described. But you know what, I actually need to look at that specific. Actually, let me do this, actually. If you go to our covid19.ca.gov website, and when you roll down there and you look at the prioritization, there is a link to a more specific job classification list that was built off the essential work list. So actually, that's the correct answer. Please go to that list, and those specific positions may actually be listed there. That's the official answer.
And this is Marcella with Social Services. If I could just add to that, I defer to Dr. Aragon on the availability, but we realize that also the county by county situation may be different, and so this is why the project is arranged in a way that allows for recognizes that the outreach may be remote, right? Might be online trainings or phone banking or other types of outreach that don't require that in-person communication. We also realize how important that is. So really appreciate the community-based organizations, all of your efforts and looking to make the best type of connection, but want to reinforce that we want to do this in a way that is safe for you and your teams as well.
Yeah, and I should add that we also don't want to be, we're going to be interacting with a lot of people on the ground. So I think that point is also being brought about by different partners, and the fear of also being individuals who are potentially spreading COVID-19 is a concern. So we just want to be as careful as possible.
Great. Diana, thank you for that question, and we'll keep watching for progress on that, and you can keep us posted at subsequent meetings. Let's go to Matt and then Denny.
Thanks, Bobby. Matt Leger with SEIU California. Just wanted to say, echo the comments about the great work that everyone's doing around the communications tools and all the work that folks are doing around this vaccine. I know it's a huge lift. I was just wondering, sort of on that point, to the extent that there may be additional grants that are going out to other community-based organizations, is that currently in the plan, or is it sort of like we've locked in the community-based organizations that we're working with now? I'm not sure who's best to answer that question.
Yeah,
Sorry.
I think that's Marcella I think is the best one to answer that, right, Marcella?
Yes, could you repeat the last part of your question again?
Sure. Yeah, happy to. So just trying to figure out if there's going to be another round of grants for other community-based organizations that may be doing this outreach work as well, or are we done with the grants on this?
So I can tell you that the state is from the funding that the CDSS is administering. We are through the Center at Sierra Health looking at any gaps we may have, and potentially there will be some more awards through the Center at Sierra Health, but it will be the balance is small at this point. What I would offer is that we have partnerships with philanthropic organizations, and it is an evolving space, right? And so I cannot say with certainty, but I have found that there have been more investments from philanthropy, and they're working on similar types of outreach projects to reach vulnerable populations. Also at the county level, the local health jurisdictions have been working in partnership with community-based organizations. So I would encourage all of the partners to look across sort of the landscape of local government, philanthropy, and the state. I hope that answers the question.
Yeah, thank you.
Thanks, Matt, and thanks, Marcella. Danny?
Hi, everyone. Thanks, Bobby. Denny Chan from Justice and Aging. I just had a question.
Danny, you got muted by mistake.
Can you hear me now?
Start over. Yeah, sorry, that was my doing. Sorry.
Denny Chan, Justice and Aging. Wanted to say thank you for sharing the videos. I loved them. I loved how multi-generational they were, how they featured older adults. Please do everything you can to disseminate broadly, and we are happy to help with that. My question is about the communication strategies that were presented earlier. I know it was a high-level overview, but wanted to know in particular, when you say 65 plus, what does that mean? How are you thinking about it? Obviously, older adults are not a monolith, and older adults, depending on who they are, have different risk factors, and I would think need different communication messages to reach them. So I know that it was intended to be a high-level overview, but if you can provide more details about how you're thinking of the 65 plus group, or rather the groups within that group, I would really appreciate those details. Thank you.
Martha, did you want to jump in, or did you want me to give it a shot?
Go ahead, Marisol. I can follow up with you. I can respond afterward.
Great, thank you, Denny. That's a great question, and we're just starting on this particular group. We plan to pull from a lot of the learnings that Martha has touched on in previous presentations with some of the formative research testing that she's done. There's a couple of different groups that have been a part of some of the research that we've done to date that we can pull insights from. I think if there's particular populations or particular recommendations that you have, we'd welcome the thoughts and ideas. I think, our focus, generally is disproportionately impacted communities, doing work in language, trying to reach folks directly, but as well as thinking through like strategies of reaching folks through, families. So I think even spots like this will indirectly touch some of those folks. but want to think about that both for our communications front, but also as we look at our on the ground efforts as well, and working with those partners that reach those particular communities to help inform our strategies. And knowing, their particular needs. So for instance, using online may not work. And so how do we ensure that they're connected to the phone number or supported through other sources that we know can provide them better support? So being very aware of where to send them to for information or for support that may be more aligned with that would meet their needs versus, just generally noting my turn.
What I will add, and Maricela's right, is we're also looking at very unconventional ways to reach the community. We're trying to think very creatively. We realize that every community across California is moving at different speeds in terms of where they're accessing information. That's also something that we will be have a close pulse on our research to ensure that we're meeting people where they are. So if they're going to social, we're going to meet them at social. If they're going to digital, we'll meet them at digital. If they're using what we call over-the-top TV, like Netflixing or doing Hulu, all these different types of programming, that's where we're going to meet them. Our paid campaign will be very nimble in terms of making sure that we meet people where they're at. We're even thinking about doing what we call guerrilla marketing, which is like the wheat postings or having posters in grocery stores, places where people are going and there's a lot of foot traffic. So we're keeping that in mind, and that's going to be informed based on data, but also reaching out to our partners. So any ideas are welcome.
Thank you. That's helpful. I would love to talk to both of you offline about how to think of the different folks within the 65 plus. So thank you.
Great. Thanks, Danny, for that question. We're going to take one more comment from Joe Diaz. Joe, why don't you go ahead? And then we're going to move on to the next
Thank
agenda.
you, Bobby. First of all, congratulations. Those are excellent PSAs and properly used, I believe, within churches, quinceañeras, and other community type that are traditional is excellent. As a former literature professor many, many years ago, Spanish, there's a synthetic problem on one of the Spanish version. You have the use of poner la vacuna. You don't poner la vacuna because you poner la máscara, you poner the tablecloth, you poner I know it's a technical thing, but the proper syntax word is tomar la vacina. It's critical because people, if you tell them, I want you to it's like saying to someone, I want to put on the vaccine. It flew out at me. So I don't know how hard it would be to change that piece, but it may not resonate with a few folks. You actually tomar vacinas, tomar pastillas, tomar medicina, and that's really, anyway, I appreciate the work that's been done, and if it's not doable or feasible to change, I think it's important. And as soon as it's available, the California Association of Health Facilities would certainly like to take it to all our 1,400 facility members. We have many, many multicultural employees and residents. So thank you.
Thanks, Joe. We need the grammar lesson, all of us, and appreciate your offer to spread the word. So thank you. So Nadine, I think we're ready to move on to the next topic on our agenda.
Yeah, that sounds great. And I do want to speak to something that came up in the chat. There was a request that when CDPH updates guidelines, if that could be sent out to this group. And Dr. Aragon thought that was a great idea. And so we will implement that. Similarly, I think from this conversation, when these are ready to go live, if it's okay with you all, Maricela, Marta, and Marcela, if we could send it all out to this group so that folks can embed it in their websites and do all of that kind of stuff, and we can leverage this wonderful partnership. And I see a question in the chat from Susan about my turn. We are going to hear about that very shortly, but right now we're going to hear an update on vaccine supply and distribution from Tomás Aragon, our director of the California Department of Public Health and our state public health officer. And then following Dr. Aragon, we will hear from Secretary Yolanda Richardson about the TPA. Dr. Aragon.
Okay, thank you. So let's move to the first slide. So what I'm going to do is I'm going to go through a few slides and just help describe it for you. So when you go to these sites, you can get some of the numbers and help relate it to what's happening in California. So this is, if you just go to the CDC website under vaccines, they have a data dashboard. So you can quickly look across the country and you can see how California is doing compared to other areas. What I want you to focus on in this slide here, when you put the cursor over California, you will see two lines. This is total delivered and then total doses administered. I want you to really focus on those two words, delivered and administered, because we're taking the ratio of that. So we're taking the total number administered divided by the number delivered, and that's how we're coming up with our percentages. So when you see what's reported publicly, that's what we're doing. And this will align with how we're calculating it in California, and how you can use these two numbers if you go to the federal website. Sometimes you'll see a little bit of discrepancies just because the CDC data will be a little bit behind. So when we divide administered by delivered, we have 75.9%, which is a fantastic number. If you remember early on, that number was it was around like 30-something%. And that a lot of that had to do with the quality of the data. And you can see the big improvements that have happened in terms of the collecting of the data. The next slide. The other program that you might be interested in has to do with the Federal Pharmacy Partnership. And it gets a little bit confusing. So the Federal Pharmacy Partnership has 3 different programs. One is called the Long-Term Care Program. I'm going to show you a little bit of that data later. There's the Retail Program, and the Retail Program is going to be with CVS and Rite Aid in California. Part of the Retail Program also has what's called the Long-Term Care Pharmacy. So, and that's separate from the Long-Term Care Program. So the term long-term care appears in 2 places, as part of the Long-Term Care Program and the Long-Term Care Pharmacy, which you will find under the Retail Program. And then the third program that's new is the program with the federally qualified health centers. And so I'll cover a little bit of that later. This specific slide right now on the CDC dashboard, they only have it for the long-term care program. So you can see there the total number administered. You see it's over 560,000. So now let's go to the California State website, which is the next slide. So when you go to covid19.ca.gov and you do slash and you put vaccines or vaccine, I can't remember what it is. It might be vaccine with an S, but basically it'll take you to the key vaccine site. And as you go down, you'll find the dashboard. So the important thing about this dashboard is the 2 words that you see administered and you see delivered. So you just divide administered by delivered. You'll get that proportion. You'll notice that that proportion is not here, but it is good to look at that proportion. The other thing you can do is you can actually select a county. And so you can look specifically at a county and then calculate for that county that proportion that I just mentioned. As you see down there, the CDC Pharmacy Partnership Program, you'll see it says here delivered and shipped. And if you go down to the footnote, it's really hard to read. You'll see there it says CDC Pharmacy Partnership for Long-Term Care Facility Program. That's the one I mentioned. And then there's a Federal Retail Pharmacy Program. And so that's the retail program that I mentioned. What you don't see listed right now is the Federally Qualified Health Center. So keep your eye out for that as that gets rolled out over time. I'm sure we'll be able to add that. We'll be able to add that, and that'll show up on the federal website as well. Next slide. And so this is just another version of the data. And what you'll see here, if you go to the very bottom, you'll see administered. And then at the very top, you see total doses allocated. So if you're trying to calculate that proportion, that key proportion that we look at, what you don't see on this slide is the total delivered. So that's missing from this slide. So you'll have to find it other places. But it does give you this, that does give you the total administered, and it does give you those that have completed 1 dose and those that have completed 2 doses. So you can see that we have over 1.4 million persons have completed their vaccination series, either with the Pfizer or the Moderna vaccine. So that's good news on both fronts in terms of total doses, and then also in terms of the number of people who have completed their series. Next slide. The other thing that you will find is you will also find the data broken down by race and ethnicity, and you could also do this by county. This one here is for all of California, and what you want to do is you want to compare this is the distribution or proportions of people that have been vaccinated by race ethnicity. And what you want to do is you want to compare it to what the population is, either for all of California or for a specific county in California. So I'll take you through this. So for example, in where it says American Indian or Alaskan Native, you'll see 0.3%. In general, that number in California in terms of the population estimate is less than 1%. So that's it's hard to really make a conclusion from that one, but I'm sure it is some underrepresentation. If you go to Asian American, you see 13% of the vaccines have been given to Asian Americans. Their population in California is about 15%. So it's relatively close to the proportion in California. Where it says Black, you see 2.9%. In California, the population of African Americans is 6%. So you see that that's an underrepresentation by 50%. So that means in California, we need to do a better job of reaching that population. The third area here, you'll see for Latino, you see 16%. And you see that that's the population of California, Latinos is 39%. So if you compare 16% to 39%, that's less than half have been vaccinated. So a lot of work to do there as well. The other area that's a little bit confusing is the one that says multi-race. Multi-race here says 13.9. That may have to do with the way people answer the survey. In the official census, people who in the official census, multi-race is about 3%. So we're not clear what other people are in that specific category. For Native Hawaiian and Pacific Islanders, it's 0.4%. And we know the population there is less than 1%, probably underrepresentation. It's hard to tell from the statistics. For whites, we see 32.7%, and the proportion of whites in California is 37%, which is approaching what you would expect to see. So basically, in terms of people of color, you'll see that we have work to do. And when you go to the site, be sure to check it out by county, so you can get a better idea of what's happening in the different counties, taking that same approach. One thing I think we probably will have to do is actually make those population proportions available to folks, so you can get a better. You can make those comparisons yourself. Next slide. It is going to be age, and you can see that 54.7% of the vaccine has been given to people above 65. And then you see the other categories as well. Remember that the first phase 1A was primarily healthcare workers and then skilled nursing facilities. So there's going to be a representation primarily of, there will be people who are younger represented there. Next slide. And we see here that females are getting, we see 58.5%, and for males it's 41.1%. So we need to make sure men get vaccinated. So we need to do a better job there. Next slide. So I had mentioned about the Federal Pharmacy Partnership, the long-term care program, and that is based on CVS and Walgreens reaching out to skilled nursing facilities and assisted living facilities. And they're currently, they should be wrapping that up by the end of February, where they've done 3 visits to all the locations. And here you see the first visit, the second visit, and the third visit. And I did present some of the some of the data earlier on in terms of the total numbers. But just this gives you an idea of how that program is going. And my understanding is, from the last time I've heard from them, is that they will be wrapping up that program at the end of February, and will have accomplished most of them. It won't accomplish all, because not everybody chose to get vaccinated, and this was especially with some of the staff. And then this is where the long-term care pharmacy program hopefully will pick up, and then also counties will be picking up as well to circle back and to finish anybody that needs to be vaccinated. Next slide. So the third program for the Federal Pharmacy Partnership is with the federally qualified health centers. And so initially there were 5 in California that, 5 in California that were selected. And then that was called Cohort 1. Cohort 2 has been added and will be starting on February 22nd. And that's going to be 8 additional FQHCs. And then Cohort 3 is going to be starting on March 1st, and that's going to be 29 additional FQHCs across California. Next slide. And so basically this slide just describes how the centers were selected based on meeting criteria. For example, the number of people that they serve that from specific priority groups like homelessness, agricultural workers, residents of public housing, and those with limited proficiency, and also the ability to handle vaccine storage and staffing. Next slide. One of the questions that came up, if my jurisdiction doesn't have a site selected yet. So at this point, I've already mentioned that we've had, we had 5 plus 8 plus 29, and there may be additional ones that are added, but I don't have I don't have information at this point if that's going to be the case, but that may very well happen. Next slide. So here is how the doses, the current plan, it says here a minimum of doses per individual service site per week. If there happens to be 5 service sites, they would get 500 for those 5 service sites. And whatever they initially get, they will be getting, that will be considered first doses, and then they will be getting second doses. So for example, let's say you had the clinic had 5 sites, that they would get 500 doses, which would be considered first doses, and they would be expecting another additional 500 doses to make up the total to complete a series. Next slide. And of course, we expect that to increase over time as vaccine supply becomes more available. So here are the projected vaccine supplies coming into the future. So you can see that the vaccine supply currently is stable and beginning to go up. We know that a new vaccine is going to be considered for FDA approval near the end of February. So we look forward to for that to be moving forward so that we get an additional vaccine in our supply chain. Next slide. And so the numbers are slightly going up, and so that is all good news. Let me make sure I didn't miss anything. I think I covered everything I'm supposed to cover. I want to turn it over to Secretary Yolanda Richardson. That's going to tell us more about the third-party partnership and the work that they're doing and how they're really going to help to administer this network that's going to improve the efficiency of vaccine delivery and administration. Secretary?
Thank you, Dr. Aragon. I really appreciate it. Hello, everyone. So good to see so many familiar faces. I'm going to give you a break from looking at slides so you can sit back and relax. I'm here to talk to you a little bit about something I think you've been talking about in previous meetings, which is the onboarding of the third-party administrator, Blue Shield. We announced on February 15th that Blue Shield would be joining the state in making sure that we have a very streamlined and efficient process for distributing and allocating vaccines. Lots of work to do, just started rolling up our sleeves. Many of you on this call, we've been talking to you about how we're going to proceed and what we're going to do. And so I thought we'd do something a little different. I mean, we're always telling you stuff and telling you what we're doing. And I think it's an opportunity to really hear what your questions are about the TPA, what kind of suggestions you might have about where we go. Just a little bit about kind of our timelines around the TPA. They've started having conversations with the counties about the provider network. And as you know, that's their primary purpose is to develop a network that can reach all of our target populations, but also make sure that we have coverage throughout the state. Right now, our conversation has been about the low supply, but we know that someday that's not going to be the case. And so we want to make sure that we have an infrastructure that's scalable. We want to be the state that gets to tell the feds when they say they have more vaccine available that we are ready to take all that they have, and so that we can definitely get that into the arms of Californians. The other piece to this is reporting and data. That's something we've been working a lot with many of you on this call, is to make sure that we have accurate data. I mean, Dr. Aragon just talked a lot about ethnicity, but there's so much more we want to know about who's getting vaccinated, where they are, and making sure that we reach the people we need to reach. And so this will be one of the primary focus of the TPA. And the last but not least is to also make sure that we are supporting our providers and supporting our provider network. You've been hearing a lot about My Turn, and many of our providers are transitioning to that platform. And so we want to make sure that we do no harm, and that we make sure that all the great work that the counties and all of the providers that have been doing this since before Christmas, that we're building on that and moving forward to make sure that we can continue the momentum that I know many of you see. So I'm here just as a representative of so many people at the state with great work and really focused on not only our network development and our allocation, but really our next steps around equity and taking that to that next step, and exactly how are we going to get this done and how do we partner with all of you. So with that, I know that's really brief, but I really would like to spend more time hearing your questions and making sure that I can answer. And then certainly if there's anything that I can address, or you have any suggestions or things that we should focus on over the course of the next 4 weeks as we transition to this new statewide vaccination network, that we keep in mind.
Great. Thank you, Yolanda. It's so good to have you here. So I know we have a bunch of hands up. I want to make sure that we start with questions for Yolanda on the TPA arrangements, and then we'll go back to questions for Tomas on the supply, if that's okay. So let me just check in. G, is your question for Tomas or Yolanda? What do you think?
Dr. Tomas Aragon.
Okay, so hold on and we'll come back. And what about you, Diana? For Tomas or for Yolanda?
I just had a general comment and trying to better understand, as the third-party administrator is working on the distribution and the allocation processes. On the ground, what we're seeing currently is that many of the guidelines, for instance, for each county is different. It varies versus what we saw in the bulletin that was provided to us, that was sent on Friday to different public health departments and vaccinators. So it's just how we ensure that we continue to use the word operationalizing those priorities. and how we can work directly with Blue Shield so that that data is also being captured on the ground. I'm not clear on whether the TPA is going to be providing the FQHCs with direct vaccine allocation, for instance, versus going through the public health departments. That's still kind of unclear. But when we're talking specifically about very vulnerable, uninsured, undocumented communities, having that flexibility with the TPA and making sure that we're working together on a registration process that makes sense outside of those huge mass vaccination events is going to be very important. So there's still a lot of unanswered questions based on conversations that are currently being had with local public health departments, and just honoring really that these guidelines are now the now word that I saw on the website was very much appreciated, but it's not what I'm seeing on county websites. So just wanted to flag that.
Diana, I think that's a great flag. I mean, we're all kind of moving kind of quickly, and this is just the early beginnings, but it's important to understand that we recognize that at the beginning of this whole process, we saw a lot of the mega sites go up, right? And that's awesome and great. And we know that that's going to be a great strategy when we have a lot of vaccine and we want to get people done quickly, but we're really turning our attentions to partnering. And when I say the TPA, when I say us, I mean the TPA in the state, really turning our attentions to those specific strategies around how do we reach those in the community. So mobile clinics, for example, and setting up pop-up sites, and how do we reach those who are homebound? Those are some of the conversations that we need to pivot to. And with the process of the TPA setting up the provider network, having that direct relationship between the FQHC or a public hospital or any provider for that matter, and being able to have that direct relationship to make sure that he or she has the allocation of vaccine that they need to reach their target population, I think will be really critical. Of course, wanting to continue to consult with the counties who have these relationships much longer than we have. But I appreciate your notice, and I think that just validates what we're trying to accomplish. Appreciate it.
Great. So David, is your question for Tomas or for Yolanda? And don't forget to introduce yourself when you ask your question.
Sure. I have questions for both. I'll start with the one to Secretary Richardson. This is David Lown. I'm the Chief Medical Officer for the California Association of Public Hospitals and Health Systems, representing the 12 county-affiliated hospital health systems and the 5 University of California medical centers, key partners in delivering equitable vaccine to vulnerable populations. So Secretary Richardson, I'm really glad you mentioned that one of the key things, as we say in medicine, do no harm as we roll out My Turn. The question is understanding that My Turn is going to play a critical role in, as you said, reaching to those aspects of the communities and partners in the communities, CBOs and others, to give them a platform for scheduling and whatnot. And understanding the incredible way that public healthcare systems and other big providers in the state are already achieving the goals of speed, equity, and transparency with data using their current systems. I'm curious to understand what problem is attempting to be solved by requiring My Turn to be used by healthcare providers and systems. I looked in the contract, I'm glad, Bobby, you included that in the email between the TPA and the state, and every time it mentions My Turn, it also says, or other electronic health system interfaced with state agencies. So just trying to understand, what is the problem that's trying to be solved by having My Turn be used by healthcare systems?
Glad to meet you, David. The problem that we're trying to solve is a consistent data. I'm sure it is not lost on you. You've seen lots of headlines around the fact that data has not been consistently reported. It's been different. It's been absent. We have not had the right or have consistent definitions of data. Having one system to do that helps that. Also with scheduling, what My Turn gives us the ability to do is make sure that we are reserving and allocating appointments to the people who need to get seen. One of the things I hear constantly across the state in terms of what's been happening recently is When you look at those who are in line to get vaccinated, it's not the people we want to be in line to get vaccinated. And My Turn allows us to make sure that the allocation of vaccine is actually going to the people that need it. Now, when we talk about other applications, that's exactly what we mean. And Blue Shield has started to enter into discussions with various providers about what systems do you use, and maybe that system actually gets us to the outcome we seek. And if that's the case, great for all of us. But we want to be clear that if it doesn't get us where we need to go, then My Turn is the platform that we will use. Is that helpful?
Yes, I think just always thinking about doing no harm, and as someone who lives in performance measurement, always thinking about balance measures.
Absolutely.
What are we gaining? What are we losing? But thank you for that explanation.
No worries.
Great. Thank you, David. And we'll come back to your question for Tomas. So Mike, is your question for Tomas or for Yolanda?
No, it's for Secretary Richardson, and I want to thank you for your transparent answers. So I first have a comment related to incentives, and then a question related to the algorithms. And so, as someone who's for the last 3 decades I've studied, I've written about healthcare incentives, I am incredibly skeptical and see incentives, and excuse my bluntness, as an insurance industry lingo for passing the buck. And I will challenge anyone to a robust discussion on the evidence for successful incentive programs in healthcare. And I think during a pandemic, our goal is to get people vaccinated. And I really just want to I am going to continue to be a very loud voice on this issue. So that's my comment. My question regarding the algorithm is, I served on the National Academy Committee that made recommendations on allocation. Honestly, as I've watched this flow, I wish our committee continued. And one of my concerns, and I really want to know who's responsible for this algorithm. And I say that because I am very concerned for the last year that clinical experts, and I say clinical experts in geriatrics, chronic disease management, underserved communities, those of us who understand both the clinical, because we're in a pandemic, but also have an understanding of workflow issues that relate and integrate with the clinical. And I am also very skeptical that any IT people are going to come up with effective algorithms. And I really believe that there needs to be a robust, ongoing, interactive engagement with experts in continuing to tweak this, because there's one thing we've learned in a year: every recommendation any of us make is good for about a day. And that's one of the challenges of a pandemic. And I think you need to have, where is Blue Cross, Blue Shield in engaging the clinical experts in older adults who represent 80% of the deaths, in the disabled, in the communities of color that also have higher rates? How are we being involved daily in these processes, and what's Blue Shield going to do with this? So that's my question.
Mike, I really appreciate your question and your comment and your skepticism. The word incentive sometimes really does have some connotations that I think make all of us a little concerned. And when this first started and we talked about vaccinating people, one of the things I said was, this is our humanitarian effort for the century, right? We all need to come in here and get people vaccinated. But the reality is providers have costs, and many of our community health clinics need some support in order for them to do exactly what it is we're asking them to do. So maybe what you're pointing out as incentive isn't necessarily the right word to use. So we'll definitely take that under advisement, because I would certainly not want to imply anything other than wanting to make sure they have the financial support to do what we want them to do. And to your point on the algorithm, this is our responsibility, and that is the state's responsibility. I am very fortunate to have Dr. Nadine Burke-Harris, who's on this call, as you well know, and Dr. Erica Pond, as the colleagues who are both passionate and committed to making sure that we are reaching the populations that we want to reach. There's just no doubt in my mind that they're going to keep us on the straight and narrow, and making sure that their expertise and professionalism, their colleagues and others have input on what we're doing. And then there's always public opinion. everything that we want to do, the governor's been very clear about making it public. So you'll begin to see more and more of this information available, and we want to hear from people, regardless to whether it's from CVAC or you as an individual. We want to hear your input. So just stay tuned. We'll make sure we provide more information, but I really appreciate making sure that what we're doing, we have a lot of those inputs, and it's just not coming from an IT system or people who this may not be their expertise. So thank you for that.
Thanks, Yolanda. So now I think everybody else that raised their hand came after Yolanda started. So we'll start with Susan, and then we'll go to Ronnie, and then Anthony. And then I know there's several others that will come next. Go ahead, Susan, introduce yourself so Yolanda knows who you are.
Hello, Secretary Richardson. Good to see you again. I represent the California Pharmacists Association. We have pharmacists in every setting, but I'm here to ask a question from our 2,000 independent pharmacies across the state, 56% of them serving very high risk, underserved populations. And the question is, when will they be included in the network as part of the plan? And then I just had a follow-up question in reading the contract about credentialing, where we would like some clarification, and we're really hoping that Medi-Cal, being a Medi-Cal provider, is going to count as vetting them as credentialed, because we just don't want to see any barriers put in front of those independent pharmacies and the needy neighborhoods that they serve.
Susan, it's good to see you again, by the way. I don't have an answer in terms of a direct timeline, but I do know what I need to do is make a note that we should follow up with you and making sure that we are addressing that, because I think you have been a very consistent voice about how do we leverage pharmacists, and we, as you very well know, we want to make sure that we're doing that. So I took that as a note to make sure we follow up with you in the next 24 hours. So thank you.
Thank you so much.
Okay, and Susan, you let us know what you hear, because everyone else will be interested in that. Ronnie, let's go to you next, and then Anthony, and then Karen.
Hi, thank you. Secretary Richardson, I'm Ronnie Kelly. I'm representing the Behavioral Health Directors Association of California. And so people with disabilities, specifically those who have a serious mental illness or an addiction, are usually best served by their current providers. So our patients who have schizophrenia, who might be very afraid that people are implanting thoughts or a GPS device in them already, or folks who are seeking recovery from an addiction who have a needle fixation or otherwise known as needle aversion, those folks would be best served to receive their vaccine through their current providers. And so in looking at the scope of work, there are a lot of requirements to get re-credentialed through Blue Shield. And I was just wondering if you knew what the difference is between the new system and CalVax, or our current system, to become a point of distribution, knowing again that the best place to vaccinate, the most successful vaccination really will be with the providers that our most vulnerable patients trust.
Ronnie, I don't know the difference between the two. It's a great question. So what we'll do is we'll follow up with Bobby, who can make sure that we can do a comparison of those two, the CalVax process and the new process, and get back to you on that. I think it's a great question. We'll do that.
Thank you very much.
Great, thank you. Okay, we'll go to Anthony, and then we'll go to Karen, and then we'll go to Maria, and then to Esther.
Hi, Secretary Richardson. Anthony Wright with Health Access California. First of all, I just want to say, as I've communicated to you before, I did have a lot of confidence when you were named in this role, given your important experience setting up Covered California. Even though this is, let's all acknowledge that this is a much more urgent task in a much shorter time frame. And so hats off for you for your efforts here. I guess, my questions, I have tons of questions, but just to prioritize them and just even the logistical ones before we get to others is just, if you could talk a little bit more about the transition, if you could talk about particularly, I think Blue Shield, what they bring in terms of a statewide network, I think is appropriate for the commercial side. They do not have the same experience with Medi-Cal or the uninsured population, which is more than a third of our state. And so what specifically is the state doing, or are you requiring Blue Shield to do to augment what they do because of their own experience? And then, like, how does that work technically? Like, so people are are we tracking who is a Medi-Cal patient who is uninsured? And are we also making sure that the people who, people are vaccinated, that information gets back into their health records, in their medical health records, so that, this is actually, a healthcare service that we are providing to folks. So, and then finally, if I could, oversight. If something goes wrong, like with the provider directory, what's the mechanism to fix it?
Hi, Anthony. It's good to see you. Always a pleasure. With regard to the network development, I think what I want to be very clear is that Blue Shield is doing that in collaboration with the counties to make sure that we're reaching that we have the providers that have the reach that they need to have. We have been in contact early on with LHPC, making sure that we're getting the data that we need on the Medi-Cal population and looking how do we overlay that with the work that we're doing so that we can make sure our strategies are targeting that population. And I definitely think those conversations are going into the development of the network and the makeup of the network. And I think I saw Andy a little while ago, and certainly lots of conversations with CPCA and FQHC. So I really appreciate their partnership. So I don't want this to be, I want to be very clear. This is a collaboration of a lot of people who have been doing this work, who understand how to reach these target populations. And this is the state of California taking those partnerships and taking that information and giving that to Blue Shield and asking them to execute on our behalf. And then that oversight is the responsibility of the state of California to make sure it gets done the way that we want. So that is metrics being in place. And Anthony, you know this very well about me. I am a metrics-driven woman. And so definitely putting metrics into place so that we can measure and evaluate our success against those metrics. And doing that on a regular and consistent basis so that if we need to make changes and tweaks, we can. This is too critical and too important for us to let this get out of our hands. And so having constant conversations with our colleagues, definitely working and partnering with our counties, reaching out to our Medi-Cal plans and partnerships, and definitely across the state of California, DSS, working with DHCS. This is not, I know where the face is and you're always hearing my voice and you're hearing Blue Shield's voice, but there is a lot of people behind here. And I do not want it to go lost on anyone. The California Department of Health, who have been doing this way before I was even thought about in this role, has always been thinking about the populations that we need to serve. And they're our biggest partners in making sure that we drive that. So that's our piece. And are we going to be perfect? Absolutely not. Do not want to say that in the least, but I do want you to know that there will be very clear metrics. And so we will have some opportunity to understand when things are not going the way that we want. We'll have that opportunity to step in and adjust if we need to.
Thank you. Thank you. Could you just practically, if there is a complaint, where would people call, and where that record comes back to, if you know those answers yet?
Yeah, I think you're just bringing up something about, one of the things that people have really been asking about, who makes decisions, Anthony. So I think that's something we need to come back with on, where do people go to when they don't like what's happening? So I will take that back as an action item for myself to do.
Thanks, Anthony. And Karen, let's go to you, and then we'll go to Maria, and then to Esther. We'll see where we have time, because I need to leave a few minutes for G to ask Tomas her comment. Karen.
Thanks, Bobby. I'm Karen Savage with the California Pan-Ethnic Health Network. And I wanted to first say, I know this is a little bit outside of the TPA, but just to say the information we've gotten this week about the FEMA sites and the ability for community-based organizations to sign up, to be able to register people for appointments and to suggest mobile vaccination sites. I just want to say we were really excited to get that from you all. And I hope that's something that Blue Shield can also replicate with some of the other mass distribution and other sites, because I think it's exactly what we've been talking about in terms of operationalizing equity. So really want to complement that and hope it can continue to be scaled up. And then my question is, there were a lot of things that are very specific in the contract about 95% of Californians being within 30 minutes or something like that. But the piece that wasn't specific was the monthly goal around reaching underserved populations. And there was a piece around Blue Shield making recommendations around operationalizing equity, which did cause a little bit of concern for me, because I do want to make sure that Blue Shield is held accountable for the equity goals. And since they're not spelled out in the contract, just wanted to understand sort of what are the considerations going into that, and how are we going to get from what you have now, which is very general, to some real specifics and accountability for the TPA around equity.
Yeah, I mean, one of the things that we've been doing is, we can reach the people through allocation. And so that's what we're working on now, is looking at zip code level information and data and overlaying that with, our, HPI work that I know you've been talking to Dr. Burke-Harris about, and making sure that we're reaching those in those lowest quartiles. And where are those providers located? And are they in the certain mile radius? This all overlaps, right? So all the metrics overlap. You have to make sure that you have providers in those communities. We need to make sure that they have the doses that they need to reach those communities. And then we need to make sure that there's access to that. So you'll see some more information around that. And that's why it wasn't so clear in the contract. And I know that left us all wanting, but I can assure you, not something that we definitely take lightly, but we want to be very thoughtful, and we need to do that in collaboration with the network. And since there's no network, that's why that hasn't been done yet. But as that gets developed, then we can be very specific at the zip code level about what our targets are, and then reporting on against that target. And as we begin to vaccinate those people, changing that target so we can keep the pressure on ourselves.
Thank you.
You're welcome.
Great. Maria?
Bobby.
Maria, introduce yourself.
I'm Maria Lemos with Visión y Compromiso in our network of promotoras and community health workers. And I must say that algorithms and metrics make me dizzy. It's not something that's in my bailiwick. No, I hate it, math. I don't understand it. But what I do understand really clearly is this statewide network of promotoras, community health workers, and outreach workers that are out there day to day doing the work of reaching our community. And so I'm not sure how we fit into the discussion because it hasn't gotten to that point yet. But I certainly would advocate that CBOs be part of that discussion early on, that you engage us and not in a superficial way, but certainly as part of the planning and the discussion. They say that our community is hard to reach. When we say we're not hard to reach, you just don't know how to find us. And so I think that has been typical for counties and for the state. And so I would encourage you to reach out to us and to really put us as part of that initial planning discussion with Blue Shield so that we can get it right the first time.
Maria, I really appreciate you bringing that up. I think that's a big piece. Anthony mentioned that I used to work for Cover California, and our community-based organizations were the very backbone of how we did our outreach and reached our target populations. And so I think you'll see a lot more information. State of California just announced our 17 million in grants to CBOs. And just today I had a suggestion on how we might be able to partner CBOs and those who can actually help people navigate this whole complicated process in the communities with providers as a strategy for how we can make sure that we reach. So I really appreciate you bringing that up, but want you to know that is on our list of things to do. If there's other ways that we can do that, Maria, that's not math related, because I understand sometimes we all need to have things come to us in a relevant way. Please let me know if there's another way that we can engage you that's just not metric related. I totally can appreciate it.
Thank you. And we actually know that we were one of the first organizations that received $1 million grant from Cover California. So I understand that they were very forward. I do want to mention one other thing though. You can tell by my email, by my note in the chat, I was a little perturbed by the discussion about community health workers, promotoras, and frontline workers, and the discussion of whether they should be under 1A. I really think that needs to be lifted up. I know hundreds of organizations whose staff are out in the community day to day. They're infected, they're sick, they don't have resources, they're being laid off. These community workers are out there day to day, and now they're dying. I know of many who are dying who you don't know because they're not lifted up. And so I really want to, again, highlight the need, the importance for the state to say something to the counties that they need to go out to the community-based organizations that they are contracting with. That is who the state and everybody's sending money out to CBOs. And still our people are going out there and they're going to the fields, they're going to the neighborhoods, they're essential workers like everybody else, and they cannot get vaccinated, except for Kim, bless her heart, who has in Riverside County has vaccinated a lot of the promotoras that we work with. In Tulare, they're doing that, in some in LA, but it's because we have relationships. It is not because there is any kind of a statement that says that they should look for these outreach workers, promotoras, community health workers, and vaccinate them. So I think that's really critical. And if somebody could move that forward, and that would be great. I just want to say one more thing. Today, the governor was in Coachella. He was talking and he highlighted the work that's being done by this collective and also by promotoras in the community, highlighted them, said, they all said visión y compromiso, at least, you know, it came out of their mouth, I don't know how many times. Not so much for us, but the work that promotoras are doing out in the fields. Thank you very much.
Thanks, Maria. Esther, you're next, and then we're going to go to G, and if we have time, to David to ask Tomas their questions before we have to end this session. So Yolanda, one more question for you.
Yes, I'd like to add to Maria Lemus.
Esther, introduce yourself, Esther.
Yes, my name is Esther Bejarano. I'm with Comité Cívico del Valle community-based organization in Imperial County. Just quickly adding to Maria Lemus, our county, as we have been working with them, and promotoras have been on that list for receiving vaccines. So I'm happy to share that. The question that I had, and actually was a conversation that resulted today with our local health hospital CEO, Larry Lewis, actually asked that question. He knew I was going to be in this platform on my term. Does it track someone, if, for example, a farm worker received a vaccine, his first dose in Imperial County, now in the next few months will migrate across the state, and so will that be tracked with my turn? We don't know. We don't have the Johnson, but that is one dose that would have been ideally, right? But now, how do we make sure that they take a dose here and they don't stay and stop working, and they have to migrate, and then they now need the second dose out in Salinas, for example?
The good news, Esther, is yes, we do track it. It's what we do with it is the question, right? So my turn will collect the administration data, both first and second doses, and then how we share that. I know many of you are very familiar with Secretary Karen Ross, and this is something she's very involved in and very engaged with, and has been talking to us about what strategies are best to reach our farm workers. I've actually had an opportunity to talk to some those who own some farms about how we do that, and I know we're hoping for the one dose, but that's not what we have. But you know, we want to make sure we at least get them the first dose. The second dose is another program. We want to get them at least the first. And so that's where I'm focused on now, is to make sure that we get onto, get to those farm workers, get the shot, but definitely something that we need to talk about is as they move on, like I've been hearing about a lot going to Monterey County, like how can we meet them there? This is where mobile clinics come into play. So those are some of the strategies that we're thinking about. But also, Esther, about what are the trusted messengers to reach that population? You know, I had this whole wonderful ideal that we were going to go to the work sites and do that. And I'm hearing that might not be the best way to reach that population. So definitely those are the types of things we want to be thoughtful about. But I do appreciate you, because it is an issue about making sure that we get that second dose, but let's make sure at least we get the first one.
Most definitely. Thank you. And I do want to add that Imperial County is very unique, being that we have over 5,000 individuals that cross on a daily basis and harvest here, and then due to the very low income wage have to go back and reside in Mexico. And so that's another, I think, hurdle that we have to come together. And so we are meeting together with local health departments and CBO, so putting a plan together when more doses come into our community. Thank you.
Perfect. Thank you, Esther. Thank you so much. Nice to meet you.
So Secretary Richardson has to get off to another meeting. So Yolanda, thank you so much for being here and answering all the questions. We'll expect to have you back for a return engagement at our next meeting, so you can keep us up to date on everything that's going on. So I'm going to let you run off, and we're going to take a comment from G to Dr. Aragon before we take a break. And David, we'll see if we have an extra minute or two, and if not, we'll come back to you later, hopefully. G?
Can you hear me?
Yes.
So I'm G. Perdigones. I'm from SEIU Local 1000, 96,000 state workers across California. This is anecdotal. I wanted to put this in the chat, but it was too long. So I have a clarification on the transition process from phase 1A to phase 1B. I have observed during multiple occasions since Friday until today that my fellow essential and healthcare workers were denied access or given a hard time accessing vaccines in the worksite, even if they qualify in the phase 1A criteria, because the worksite decided or the management decided to rush to start to phase 1B. They changed the dates for the second doses without adequate notice, different from the CDC. You know how you get a vaccination card after you get the first dose, and then allocating and vaccinating inmates over healthcare workers by shutting down a full day of vaccination to accommodate inmates over frontline healthcare workers, denying a new mother, postpartum mother who is on maternity leave or baby bonding leave, who qualifies as an essential healthcare worker to come into the worksite so she can get her first dose of COVID-19 vaccine, and requiring her to get a medical certificate or clearance to get a vaccine today, leaving a number of some of our nurses and frontline essential workers on phase 1A in the prison system with only about 60 to 68% protection from Friday to today. I made multiple phone calls from up down the chain of command, waiting for answers, but shouldn't the process be prioritizing and vaccinating all the healthcare workers who volunteer to be vaccinated in phase 1A or who qualify in phase 1A, while also transitioning to phase 1B, keeping in mind giving access to all who volunteer to be vaccinated if they fit into the criteria? This is only the way that we could actually resolve the vaccination hesitancy and the distrust in the system. But as I've seen it in the ground, the second shots of phase 1A was challenging than the first shots. So people might see this in the future once your constituents or the criteria expands. But what is really the process? Shouldn't we actually finish phase 1A or before rushing to phase 1B? Or what is really the allocation and distribution process when it comes to transitioning between these two phases?
I'll go ahead and answer that. So the way it should happen is that phase 1A should continue even as you start phase 1B. And the analogy is when you board an airplane, people who have priority boarding, they have their lane, but as you open up the other priority groups, you still allow people who were in the first priority lane of boarding a plane to move forward. That's how it should happen. That's how it should be happening. And that's actually one of the reasons why we need to move to a state system where we really need to build in consistency around these types of policies so that it's uniform across California. So thank you for bringing that up. It's very important.
Can I do a follow-up question, Doc?
It has to be really quick, G, because we're ready for a break and we have lots more to go today.
Very quick. So the process would be CDPH or local CDPH has the guidelines, or is it the work site that has the guidelines?
Well, you're bringing up a point that should be obvious to folks, which is just because you're moving on to phase 1B, you're still going to continue with phase 1A because there's going to be people for a variety of reasons have changed their mind, coming back from vacation, maybe they were out on leave. There's going to be people who still need to be vaccinated. And so you have to continue to vaccinate them. They may be a smaller number, but so that what you described should not be happening.
Okay, thank you, Dr. Aragon and Dr. Burke-Harris. I think we're ready for our 10-minute break before our My Turn demonstration.
Fantastic. Well, we will, it actually is, I think we have My Turn on the agenda for 4:55. So it'll be a 6-minute break and we will see you all at 4:55. Thank you so much.
Perfect. David, sorry you couldn't ask your question. We'll try to get back to it. Or write it in the chat and maybe he'll answer.
I'll see if I can do that.
Or I'll give you his email and you can email him.
Yeah, that's the other alternative.
I hope it wasn't, was it the question that you put in the chat that I told you to ask it when?
Probably.
Yeah, I can totally blame it on you, Nadine. That's no, it was a combination. It was that and something about the increase in dosing. I'll see if I can put it in the chat.
Okay.
Yeah.
As
if we have
someone sort
time
of
at the end.
as balancing Maria's comment that I only understand things in numbers and algorithms. So
that's great.
Funny. Oh, okay. Here we go. Okay, Eric, just give us a second till we get everybody back and introduce you.
That's my teaser screen.
Yeah, no, I'm glad you did it because you know, we all have technology phobia that it won't work. So great.
Bobby?
Yes?
When they discuss my turn, it might be good to let them know the difference between my turn public, my turn clinic, my CA vax, and care. Because I think, yeah. Okay, fantastic, great. Because that'll really help people because it gets confusing. Thank you.
No, thanks, Tomas. That's great. So Eric, you do it or Tomas will jump in and add to it. So I have 4:55. Nadine, you want to bring us back to order?
I will do that. Yes, I was just responding to Anthony's comment in the chat. All right, welcome back. If we can get everyone to get their cameras back on, we hope that you all participated in a little wellness stretch or helped yourself to some water or did something to support your well-being, maybe hugged a loved one. And now we have an opportunity for a demonstration of the My Turn platform from Eric Norton at CDPH. And with that, and I did see that there were a number of questions in the chat earlier related to My Turn. And so I think as we're heading into this conversation, Eric, some of the questions that you may want to think about from the chat. One was, does the My Turn system have the ability to track, for example, migrant workers, right? That we heard that was asked previously. I think there were questions around, oh gosh, I don't have all of it just right in front of me, but as we go through and as we get to the end of the demonstration, I'll try to keep an eye out and raise up the questions that are in the chat. So with that, Eric, do you want to go ahead?
Thank you, Dr. Burke-Harris. So just, again, Tomas brought up a really great question at the beginning, and that is kind of there's a whole, and this is such an overused word, but an ecosystem of just kind of systems that are out there to service the vaccination needs for the state of California. The one that people know about probably is My CA Vax, which is formerly CalVax. My CA Vax is kind of the backbone of the system. It's actually, we can pull up actually, so it's basically the system that we're using for ordering and vaccine distribution right now. And then there was also discussion of My Turn public and clinic. So what we're talking about today is My Turn public, what we'll be demonstrating for you. And this is the public access point to register for and schedule first dose, second dose vaccines. And then there was a mention of care, and care, it's called Care 2. And Care 2 is one of the IIS, or it's the immunization information systems. There are 3 in California. There is Care 2, which is the main one for California. There's SDIR for San Diego, and there's RIDE for 8 Central Valley local health jurisdictions. And so what happens is, after, in this case, working with my turn, after the injections, a person gets an injection, that information then is uploaded to the IAS, which is then the repository for injection and vaccination information for the state of California. So that said, what we're here to demonstrate today is My Turn Public. And what I'm going to do is walk you through a couple of flows. The first one I'm going to walk you through is basically a successful registration. Someone's eligible and there is vaccine available. The second is someone's not eligible, and what their flow would look like, or it's also the same flow you get if you're eligible and there's no vaccine available. And then if there's interest, we could walk you through a targeted flow as well to show you what the targeted clinics, and I'll explain what a targeted clinic is when we get to that. So looking at kind of the successful flow, I want to mention that it is currently in English and Spanish. It is a super, super high priority for us into 8 languages. The 8 languages from the COVID-19 website, which is English, Spanish, Chinese traditional, Chinese simplified, Korean, Tagalog, Arabic, and Vietnamese. So our goal is to get that by this Friday on the site. So as soon as we have that available, we're going to breathe a big sigh of relief, because that's a high priority for us. So presently, I'll take the English flow, and with that, we drop into just a couple of checks for just certifying that you're 18 years old, that you understand the information you provided is for eligibility determination, and that's it. Some required information if you provide that you're a licensed healthcare worker, and then just again a privacy statement. It's important for us to make sure we put that up front. After selecting those items, there's just a few simple questions we ask to determine eligibility: age range, industry, and we're adding a couple new ones this week: retired and unemployed. But I'll pick healthcare worker, and then select the county. We're going to go with Los Angeles. And then the accessibility code is the targeted code that we're talking about, and I'll give you a demonstration of that a little later on. So after entering your information, the system comes back, says, congratulations, you're eligible. Find a location near you. So what this does is, before I get into this, also, if you'll see at the bottom there, we have the ability for chat. There's an automated chat that goes along with this for that links people with frequently asked questions. We're monitoring the use of that and always continually improving that. And then there's also the phone number for the California COVID hotline, which people can access to either have questions, get a walkthrough of the registration process, or also have people on the call center register for them if they don't have internet access or otherwise. So for the searches, I'm going to start typing in a zip code, and as you can see, it auto-completes as I'm moving through. So we're going for Los Angeles 90026. And it lists the clinics that are available. You're seeing as we build out, we're going to have other providers, Kaiser and such, that will be in here. We're going to have links to them as well that show how far they are away, but it takes you away from the site itself. This is our UAT environment, so it's got a couple things in here that aren't open to the public yet. We'll pick the Getty Clinic. Shows there are 96 appointments available. Pick one at a reasonable hour. Go 9 a.m. That's the first dose. And then the second dose, clinics can schedule themselves as a first dose or only, or as a single dose clinic, or both doses. In this case, this is a 2-dose clinic. Most of them now are scheduling as 2-dose clinics. Some of the single dose clinics were set up for people who are transitioning. So we want to do like a second dose only clinic, or a clinic that was only going to be up for a little while. We'll schedule for 9 a.m. again. I have both my appointments. I can cancel those. I can go back. I can change my location, we can do all that. So once you get through and you've actually registered both of them, I'll put my information down. I filled this out a few times. We have gender, male, female, non-binary, prefer not to say. We have race. Let me see if I can pull that up so I can see all that. So we have race, number of different designations and sub-designations of that. And then Hispanic or Latino origin. And then phone number and email address. The email address is optional. The mobile number is required. Address. And then we ask optional question for healthcare coverage. If you answer yes, then there's some simple information that is required. If you say no, then you can move on. And then we have 13 CDC questions that are asked. These don't preclude your eligibility, but it is information that we pre-send to the clinic. So at the day of the clinic, if you've answered yes to these, you can get clinical. They can refer you to a clinical individual to kind of clarify and see if there's a decision to proceed or not. Again, bleeding disorder, pregnant, breastfeeding, have you ever had dose COVID vaccine? Obviously for the second dose, it would be yes. At this point, to keep from having bots or fraudulent activities that occur, we actually have the system sends you a code that you can enter. In this case, I got it by email and text message. If something happens, I can resend that code or go back and check on the information that I have so that I get it. And at this point, I am confirmed. I get a confirmation email that has a QR code on it that you can print out and bring with you, or you can have on your phone. I get also an SMS message as well. And then I can, if something happens, I can cancel the appointments from either the SMS or from the email that I get as well. And that's the successful flow. Take you back, show you what happens if something's not available. Again, we've seen this. I'm going to check them off. Communications and IT, so I'll be truthful here. And we'll go Sacramento. And it shows based on your results, you're not eligible at the current phase, and it asks if you'd like to register for additional notifications about it. And again, at this point, same information as before. We do have to, at this point, re-enter the eligibility criteria. And we go for the year, so that helps us kind of group things as well. And then ask a couple of questions about, we have a lot of planning ahead for comorbidity activities, but at this point, we're at least asking if there's any underlying health conditions, and we have links out to where you can have more information about what qualifies as an underlying health condition. And again, race and ethnicity. And then we ask questions about long-term care, congregate or homeless shelter, group home settings. And the email address, so you can register at that point. Oops. 9-digit zip code. We have validations. And at this point, then as I become eligible and vaccine is available, we work with the local health jurisdictions to send out notifications to individuals in those areas so that then they can come back on and register. And then, as I mentioned, we also have the accessibility code route. I could show that if you're interested, but basically what that enables us to do is what we call targeted clinics. And that enables us to, what happens is if we're looking for a special population, Medi-Cal, Latino, areas, heavily densely populated areas, any type of that type approach, what we can do is we set up clinics that link to those codes. And then we have the ability to work with our local health jurisdictions, community-based organizations to distribute those codes so that individuals can use them to register. What this does for you as well is the current functionality is with an accessibility code, you bypass the eligibility criteria because, again, if you're receiving this, there's a reason for that. We want you to have the accessibility to the vaccine, densely populated areas, congregate care, whatever that may be. So you enter the code, and then the system will show you that actual clinic itself. And then if you're actually eligible as well, what you would show is that clinic and then any other clinics with which you have eligibility. So you don't necessarily need to use that code at that point. And that concludes our demonstration of My Turn Public. I want to see at this point if you have any questions.
Thank you, Eric. We have a number of questions in the chat, and I think between Nadine and I, maybe we can ask those of you first. And then if we have more time, we can open it up to members. What do you think about that, Nadine, that approach?
That sounds great. Yes, I've been noting all of these questions.
Yeah, me too. So why don't you start and then I'll fill in.
Great. So so one of the first questions that was actually from before you started was, who owns My Turn?
Well, it's the state of California.
Great.
CDPH.
Yes. Okay. Wonderful. Thank you. And then also a previous question, which I think you responded to. The question was, does My Turn include everyone, all ages, and all categories of eligibility, whether mega site, community clinic, or doctor's office?
When you say include everybody, I'm curious about what that means. Can anyone use it as far as like setting up a clinic on it, or what's the?
Yeah. So I think the question is, can anyone use it? You know, any age, any category of eligibility. We saw that you tested that, and then the appointments. Do they go to community clinics and doctors' offices as well as mega sites?
So the current we're working on our focus to deploy this. Obviously, there's a lot of pent-up demand and also urgency to roll on board with this. We're focusing on local health jurisdictions right now and a number of providers, and so we have a subset of providers we're working with, and then also we just recently on board. So live in the system is San Diego, Los Angeles. We've got a number of Central Valley. We have, I think, 9 local health jurisdictions that are on board right now. And then we also have Kaiser Permanente opened up a mega clinic in San Francisco and also in Pomona, Los Angeles. And then finally, we have Dignity, actually 2 more. We have Dignity that opened up a mega clinic this week in Carson, focusing heavily on Medi-Cal patients. And then we also have FEMA and OES that have jointly opened up clinics in Oakland at the Coliseum, and then in Southern California as well. So as you can see, we're really trying to focus on getting the local health jurisdictions on, and then these bigger clinics that have the ability to really get vaccine out there to people, and then we're trying to build out from there. The state of California has a third-party administrator, a TPA, they've recently brought on board, and that TPA is also working with us to make some of the decisions about priorities and capacity to deploy the system. So we're trying, our internal goals are to get this out there as fast as possible, but we are constrained by, throughput, by capacity.
Thank you. And another question was, there were a number of questions about languages, And you mentioned that there was a plan to increase the number of languages by this Friday. And the
Correct.
question was, is there a plan to, beyond this Friday, increase the number of languages? One question asked about the 15 Medi-Cal threshold languages, and then another question asked about African languages.
Yes, we have heard some of those questions. I think actually, if we can get that feedback back to us, that'll help us with our prioritization. You know, we have these 8 languages that we want to get into first, and then you know, we are also, you know, there's that tired phrase, but it's so true: building a plane while it's flying. So you know, we are balancing language and accessibility with also just, you know, basic functionality for the system as well. You know, as it was mentioned, there's the clinic side, My Turn Clinic. So we're building out functionality to make sure that when people do arrive, that their process flows smoothly and that people have access to the information that they need there as well. So there's a lot we're building out. We would certainly take additional language suggestions in for consideration so that we can build that out as well.
Wonderful. Several questions. What happens if someone doesn't have a mobile number?
Smartphone.
So if you have an email address, you can put your hard phone in there and you'll still get the email confirmations as well. So the confirmations and the notifications go out via email and SMS. So if you have an email address and you don't have a cell phone, you can use your email address. If you have neither, we are encouraging people to contact our call center and to work through our call centers to book those sites for them. And currently, our functionality is that we are taking building the email and phone number into the call center numbers, and then the call center agent is sharing the booking information with the person who calls the call center. Technically, when you show up to your appointment, you don't need any booking or the QR code or any of that. You do need, obviously, if you're a healthcare worker, you need to prove you're a healthcare worker. But ID would be nice, but it's not even required at all. You just have to give them your name, and if your name matches, then you can pretty much go through at that point. So yeah, so there's no need for a phone or an email, although it is an easier experience if you do have either of those.
Thank you. Some other questions. There were several questions about can family members or someone who's helping someone sign up for My Turn? And there are a number of folks who actually shared positive feedback that they have been doing that and have found it very simple and easy to do. The question was, does the family member or caregiver need to be explicit that they're signing up for someone else, or do they just put in the information?
Yeah, I registered in my county for my mom. So yeah, you can register on behalf of someone, although we do have the ability, we are building out deduplication so that you can't have, say, Eric Norton with the same email address or same mobile number registering 6 times, right? We don't want that to occur, but we do want to make it as easy as possible for people to register on behalf of. So you could register for your neighbor. If your neighbor is an elderly person and you want to help them out, there is that ability. We don't discourage that at all.
And in the Q&A information, is there information about the physical accessibility of a site? For example, for an individual who needs accommodations, how far they might have to walk, or if they have a developmental disability?
That's a great question. One of the things that we are prioritizing to build out is the asking of if assistance is required, if assistance is needed. So then the clinic will know in advance individuals who require assistance so that they can be prepared for that. As far as like how far a person would have to walk, we don't necessarily have that information in the system yet. A lot of the clinics that we're seeing, but even with that, we still want to make sure if there's accessibility needs that we're capturing that so that people can address those.
And speaking of accessibility, I know that you mentioned the call center, but the notion is for individuals who don't have access to or not comfortable using the internet, they have access to, anyone can also call the My Turn call center and register that way, correct? Good old fashioned telephone?
Good old-fashioned telephone. All you need is the landline and the phone number.
All right, fantastic.
The system also does do walk-ups as well, so we can do walk-ins. We've heard from a couple of sources that, you know, in some instances, people who are uncertain or you know, insecure about their citizenship, you know, they can just, you know, show up as a walk-up, and you know, obviously they have to have the eligibility, but they can show up as a walk-up, and we can process them as walk-ins as well.
Great. And then a couple other questions. One was a question about updating eligibility. As mentioned, the CDPH just released updated guidelines about individuals with underlying medical conditions and or disabilities. Is there a sense of when that might be updated?
I'm sorry, which one for?
Of updating eligibility for individuals under 65 with an underlying medical condition.
Yeah, that's so the system. So a couple things about the system. You know, the policy that gets set, we execute. At current functionality in the system is that the system is able to have eligibility set by the local health jurisdictions. So let's say, you know, they want to activate a tier or activate an industry, we can activate that for them. But we don't, you know, we don't set when those tiers become available. We you know, by default go with the state eligibility.
Oh, great. One other question: do screen readers work on My Turn?
I asked that question with the developers of the system. They said yes, it does. It was tested when it went live, and I've asked them to run a follow-up test to make sure that any enhancements we make on it will continue to operate with the screen readers because that is important to us. So we are that is something we check with.
Is there an option to specify that an individual is homebound or needs transportation?
We do not have that currently. I'll capture that.
Thank you. So there's a question that I want to. I think there's two parts to it. But in any case, does the question about disability or underlying health condition make it a self-certification attestation system, or will verification be required?
Again, with regards to that, we're building that out. We have several meetings over the next week and a half to take care of that.
So I want to do a little assist here with saying there's a question about what is required in My Turn,
yes,
versus what is required when you show up at the vaccine site, right?
Yes.
And
okay.
So what's required we prepped on this just as to, you know, out here. A lot of these questions that you guys are asking, we were peppering Eric before. We're like, you got to answer this and this and this. So this is great. So particularly when it comes to the My Turn system, we want to make it as easy as possible for folks to access and get an appointment. The separate question about how vaccinators, for example, verify. So for example, in the policy that was set on Friday, the verification of eligibility of the assessment of eligibility of a pre-existing condition that increases the risk for COVID-19 or a disability has to be made by a healthcare provider or certain entities. So some of that is going to be operationalized through My Turn, but some of it is not.
So we will continue with the system itself. We're trying to, you know, we've actually been talking with local health jurisdictions that have implemented the system, and there is some gaming of the system, and you know, that's up to the local health jurisdictions to assess. You know, when we first went live, that was a little higher, but now that we've been live for a couple of weeks, they're seeing it decrease, and you know, basically, you know, normal populations are you know, it's just taking care of itself, right? And so you know, our goal is to, you know, to set to make the system as accessible as possible, we think that there's acceptable levels that people are. If we make the system so ungameable, right, and we put all these criteria, and you have to scan, you have to upload, and you have to do all these different things, it makes the system it degrades the usability of the system. And our goal is to make the system usable. And again, a lot of those determinations as far as what qualifies will occur at the site when the person goes in for the vaccination, if there's something that has to be.
Another question is, how does My Turn coordinate with CVS and Rite Aid?
We're in conversations with both of them right now. Yes, we're in conversations with both of them to try and work that out. So you saw a little preview of that on the user acceptance testing screen when we were talking about an outside clinic that's sent. I think if I look in my crystal ball, what's probably going to happen is when you get after you go through your eligibility, you'll get a link to their site to go through the process, but it won't be a warm handoff at this point.
And one of the questions, has there been consumer testing done? And it sounds like folks who are part of this body would be happy to participate in any consumer testing.
We have, there has not been consumer testing. The consumer testing has been with, again, a little bit with the local health jurisdictions that have gone live with this. We've worked very closely with them, and we've solicited their feedback and user feedback. We've had them out at the clinics, informally asking individuals about their experience with My Turn and getting their reservation and through that process. We are looking to build in those measures to the system, both from a standpoint of booking your appointment and also through the clinic experience as well, but we don't have that in yet.
Thank you. I'm reading as fast as I can. Bobby, do you want to help me out?
Yeah, no, happy to.
Comments are
happy to. So Eric, one of the comments is because you asked for health insurance, is it possible for the information about getting the vaccine to be linked into a person's medical record?
We've been working with our, so with Kaiser, obviously they have a clinic, and Dignity as well, because they have a clinic. We're working with them to enable them to extract that information so that they can match it up to their own clients' records and have that matching on their end as well. So we are thinking about that. We are looking to, again, make improvements over the future on that, but we currently have the ability for them to do that.
Right. And then a couple of questions about demographic information. When is that collected about the individual? Race, ethnicity, gender, age, etc.
So it's not collected prior to eligibility determination, but after eligibility determination, that's the point where we make those questions available. And those questions, again, follow both paths, the path of I am eligible and there's vaccine available and I have an appointment, then we capture that information. And then there's the second path, which is I'm eligible, but there is no vaccine available or no appointments available at this current time within my area. And so then I can enter that information. So then that helps us make determinations with regards to potentially targeted communications that we can send out.
Right. And then there's an important question about, is the Healthy Places Index able to be accounted for through My Turn?
I don't have an answer for that. I can follow up with Dr. Burke-Harris on that one.
Yeah, I think the short answer is that one of the things that we are working on is as we are looking at utilizing allocation as a tool for equity, right? Reaching our highest risk populations. One of the things that we're working on is understanding if there's a way to build into My Turn a way for certain a certain number of appointments to be reserved for certain groups. So, for example, if a CBO has is doing outreach to a particular community, if there's a way to reserve appointments for folks living in a particular zip code or census tract or something along those lines. So that's one of the things that we're looking into as we're working to operationalize some of our equity strategies with the My Turn system.
Yes.
Great. So another question that was asked several times, and you did it, Eric, so you can tell us about your experience. You enrolled one of your parents.
Correct.
If you used your own email address and then you wanted to go back in and enroll yourself with the same email address, would it accept you?
Yes, 100%. I could use my email for both of my parents, my neighbor. I could use it for all of those. Then at the time that I want to register myself, the duplicate check would be looking for my name and as well as the name and the birth information and the phone number as well. So there's multiple criteria you have to tick before you get flagged as a duplicate.
Great. And then maybe one last question, and then we'll have to move on to our next agenda item. How are the accessibility codes shared or distributed? How does that part of the process work?
We're still working through that. We've been the current approach that we're using with that is that we're working with the clinics that actually use the accessibility codes to enable them to distribute that to the populations they seek. So with Cal OES, they were working with a number of community-based organizations in the areas where they opened up their clinics. So we worked with them to determine how many codes they wanted, and then we generated those codes and sent them out so that they could use them.
Okay, great. So Eric, I thought after the meeting I would send you the entire list of questions related to My Turn, so you'll have them in writing.
That'd be very helpful.
And
thank you very much.
We can give an update at our next meeting. Perhaps you'll come back and update everyone on all the improvements and any additional questions that people have as they begin to use it.
Thank you. I appreciate that.
Great.
I do have to go. I have another meeting.
Thank you so much. It looks like everybody appreciated your time and your expertise in going through this with us. So thank you.
Yes, thank you so much, Eric. Thanks for all of the hard work that you've been doing on this system. Much appreciated.
There's a lot of people working on it, and your input will make it better. Thank you.
And now we're going to move forward with the recommendations regarding underlying medical conditions and people with disabilities, and an update on access strategies as well. So I will turn it over to Tomas Aragon, the director of our CDPH and the State Public Health Officer.
Thank you. So you can move over to the next slide. So let me start off by just giving you a little bit of a history. During the surge, the health department became very focused on what was happening in the surge and who was being impacted. People who are older, people of color, primarily the Latino community. And we really started thinking about age and how we can prioritize age. Age had already been already set as a priority of phase 1B, tier 1, where it was 75 and older. As we were focusing on that, the prior administration came out with guidelines expanding the criteria over 65, persons with medical conditions from 16 to 64. And so all that happened very fast. And so we spent time both getting input and also looking at the criteria to see how can we really do prioritization that takes into account. The idea is that how can we save lives, achieve equity, given the supply shortage that we had. And so the other thing that we had to focus on was actually how can we incorporate speed and simplicity. because we recognized we really needed to vaccinate people as fast as we can. And as you can begin to see just from the My Turn discussion, you can see the complexities of implementing systems about verification, codes, and just that whole process of how do we do that. And it's a real challenge. And one of the things I just want to share with you, sort of a principle that just comes up in decision making, and everybody knows this principle, but it's kind of just it sort of reminds us how hard it is to do this work, and that is there are no absolute right answers. There are only trade-offs. And so in decision making, regardless of what we decide, there's always going to be trade-offs, and so it's never going to be perfect. But anyway, starting off with saving lives, achieving equity, we have a vaccine supply shortage. So we want to focus on speed and simplicity, and we want to reach the most where we think we're going to have the most impact. So on February 12th, we did publish starting on March 15th, expanding the criteria with people with severe chronic medical conditions and disabilities. We recognized that if we started with the CDC framework. The CDC framework has two different categories. One is people at increased risk for complications from COVID, and those that have that might be at increased risk that has a different conditions. And we recognize that even if we were to implement the first list, that there would not be enough vaccines. So we had to narrow that list even further. And the drafting guidelines group helped us with that. We've been working with disability groups or associations that represent disability groups to help us define disabilities. And there's still work going on in that area, sort of really fine-tuning that definition so that it can be operationalized in a practical way, recognizing that we're not going to be able to, there's not going to be a definition that's going to be completely inclusive of everybody. So there is going to be a gap. As vaccine supplies improves, we'll be able to broaden that. I'm just going to read to you, for example, it says here, beginning March 15th, healthcare providers may use their clinical judgment to vaccinate individuals 60 to 64 who are deemed to be at very high risk for morbidity and mortality from COVID-19 as a direct result of one or more of the false severe health conditions, or if as a result of developmental or other severe high-risk disability, one or more of the following apply. The individual is likely to develop severe life-threatening illness or death from COVID-19 infection. Acquiring COVID-19 will limit the individual's ability to receive ongoing care or services vital to their well-being and survival. And providing adequate and timely COVID care will be particularly challenging as a result of an individual's disability. And so we're in the process of that. You're going to hear a little bit of the implementation later. I just want to sort of give you a concrete example how this might apply, and I'm going to use me as a personal example. So I'm 61, so I would not qualify right now under people who are older than 65. I work in public health, but I'm not a frontline healthcare worker. So even though I'm a physician, I'm not a frontline healthcare worker actively seeing patients who might be infected with COVID or providing care for patients who are COVID. So under that category, I have not been vaccinated. My wife, who's 54 years old, is a public school teacher. She teaches first grade. Right now, she's working at home teaching Filipino bilingual, and she's been teaching virtually. Right now, they're planning to go back into the classroom. She lives in San Francisco, so she will qualify under phase 1B as an educator planning to go back into the classroom. I have 3 children, ages 20 to 24. My 22-year-old, who recently graduated from college, has asthma. And so his condition fits under this, what might be increased medical risk, and would currently not qualify because of his asthma. And he actually, that asthma is not part of that first list. So all of us, so my wife will be qualifying. So all of us, until it's our turn, we've registered on my turn and wait for our turn to be vaccinated. In the meantime, we have to continue to practice what we know, which is masking, physical distancing, doing things outdoor, trying to minimize risk of getting infected. I should just mention, my other son works in retail. He gets exposed to persons every day working in retail. And then my daughter, who's is doing virtual learning, is in college right now and is just living at home doing a virtual learning. So I just gave you sort of give you a concrete example using myself, my family, my children to sort of help you understand this. So the conditions that are there, hang on for 1 second. So I gave you a little bit of background how that works. And so what I'm going to do is, so a lot of thought went into this. We recognize it's not going to be perfect. We recognize that there are going to be gaps. There are other gap areas that we're going to have to address, and we're going to try to find ways. CDPH is going to try to find ways of really closing that gap, working with our county public health, our public hospitals, persons who focus on, for example, on the homeless. We know that there's a gap with behavioral health and mental health issues and persons who have substance use. Those are gap areas that we will have to address. So I do want to call that out as an important area in terms of equity that we will have to close. We will have to close that gap. This specific list doesn't address those explicitly, and we hope, as we address working with the locals around the issues of equity, that we address those in a more systematic way. So that's all I want to say for those two slides. I want to go ahead. I believe we have another presenter that's going to go ahead. I think, maybe Dr. Oliver Brooks may make some comments. He's from the drafting guidelines group. And then Kim McCoy-Wade will make some comments with respect to the implementation group work that we've been doing with the disability group. So let me ask Dr. Brooks if he has any comments that he would like to add.
Yes, thank you, Dr. Aragon. I would only add that the drafting guidelines work group worked on these through our most current meeting and through the 12 meetings that we've had to get us to where we are now. These were submitted to the state, and the state made the final determination as to how we will exactly structure this part of phase 1B. I would say that you should see from the CVAC, your fingerprints are all over these recommendations. What was taken to the drafting guidelines work group from your recommendations was integrated into all of this. So I just do hope that you see that. And I will lastly say that covid19.ca.gov/vaccines is the site where you can see most of the things, almost all of the things that we discussed today, including this, and there is a link to the provider bulletin that was released February 12th.
Thank you, Dr. Brooks. Kim, do you have any comments for I think you were going to cover the next slide.
Yes, thank you, Dr. Aragon. Thank you, Dr. Brooks. I'm Kim McCoy-Wade, Director of the Department of Aging, and with Dr. Aragon and Nancy Bargeman from the Department of Developmental Services, the three of us are convening a group at the request of Secretary Galley from Health and Human Services and Secretary Richardson from GovOps about the how. We've been talking about the who, the why, the when, but how. And I know that I want to give you a quick report back on the work of that group, and then I'm going to hand it to Vance Taylor to talk about what's happening right now on the ground in some areas. So very briefly, this was a group that was convened. It's a small working group of 11 folks. About half of them are members of the CVAC, representing disability and aging and labor. And we also have Dr. Larry Yin and Dr. Alyssa Burkhart in the group as well, and California Medical Association. So thank you to those of you for jumping in on yet another work group. You see here some of the topics in our first two meetings that we have begun to dive into, and many of them were just covered in the My Turn demo. So I just want to lift up a few areas of focus for us right now. One is very much mobile points of distribution, how to partner with community sites and go to where people are. Another is transportation. How do we leverage and arrange transportation for everyone to access sites. A third is in-home options, very important. And a fourth is what I would call kind of outbound registration, not just the inbound, letting the public make phone calls or to my turn or sign up on a website, but how can partners book appointments on behalf of clients or participants in certain programs and services. So kind of that, I heard that come up in the demo as well. That kind of navigator concept that some of us are familiar with other program outreach and enrollment efforts. So those are the areas where we have been discussing in our first two meetings. Our next step is really a deeper dive working meeting with the third-party administrator, which of course folks know came on board this week, and I hope have seen the overview and the contract of their work. And so we will be doing that more at our next meeting next week. But didn't want to leave you hanging, and there is incredible work already happening on the ground on a couple fronts. On mobile and home, we are really seeing great work happen. Again, many of the issues that people with high-risk medical and disabilities have are also present in the aging community. So older adults already are needing mobile sites, at-home sites, transportation options, et cetera. And so I just want to really shout out what we're seeing in places like Contra Costa County and San Diego County to really develop those models. And we're looking to see those kind of best practices carried forward as we change planes to the third-party administrator. But I also wanted to give Vance a chance to talk about what's happening on the ground at the OES sites in terms of accessibility. So Vance, if you're here, can I hand the mic to you?
Absolutely. Thank you, Dr. Wade. Appreciate it. Hi, everybody. I'm Vance Taylor. I'm the chief of the Office of Access and Functional Needs at Cal OES. And essentially, our office exists, but for those of you that don't know, our office exists to help ensure that anybody, older adult, person with a disability, anybody with an access or a functional need is able to have the same access to emergency services, and to make sure it's got identified before, during, and after disasters, and integrated throughout the way we plan, respond, and recover from disasters. So with regards to COVID and vaccines, one of the things we're doing that is very exciting is President Biden has chosen California to be able to stand up some mega vaccination sites. And they're using the word mega, I guess because it sounds cool, but they're very large sites. And one is in Oakland at the Coliseum, and the other one's at Cal State LA. And the idea is to set these up and run them. We had a soft opening yesterday. I'm sorry, yesterday was the first day. It was a hard opening. The goal is by the end of the week that we'll be vaccinating 6,000 people a day at each site. To ensure that those sites are physically and programmatically accessible, we did things like ensure that there's ASL interpretation. So there's in-person interpreters there. Also, every staff member has an iPad, and it's got a VRI app, video remote interpreting app, just to supplement that in-person resource. We've got in-person interpreters from representing 6 different languages. We also have telephonic language services to supplement that. We've got Just Ask signage. We've got signage to and from transportation hubs. We've got things like a designated lane for paratransit. We're also working with partners like BART and AC Transit and Access Services LA to provide free paratransit services to and from the vaccination sites, and free accessible shuttles to and from bus stops and train stations. And we've got a whole host of other resources there, like wheelchairs, isolation rooms if people have sensory issues or can't wear masks, temperature controlled tents, chairs with and without armrests, accessible bathrooms, porta potties, hand washing stations. We work with the Pacific ADA Center to develop a fact sheet and a list that everybody's being trained on. And so far, we're hearing really wonderful things about the physical and programmatic access at those sites. All that to say, these are things we care deeply about. These are things we're committed to. And the implementation of those things in partnership with our CBOs is something we're very proud of. Real quick, each site has 2 mobile clinics associated with it. We're working with our community-based organizations to get those mobile clinics out to the community. So I can tell you that so far, for example, we've worked with 3 ILCs to schedule those mobile units. We're working with 2 agencies that work with people who are deaf and hard of hearing, and a multitude of other CBOs to get those sites calendared so they'll deploy and go out to the community. And each of those mobile sites can vaccinate 250 people a day. So good work going on. A lot of it, of course, in direct result of the input received from this group. So thanks to all for that in the report.
Thank you, Vance and Kim. Great update. And I hope that we can keep getting updates from the Access Work Group and also from all the accessibility efforts that you're involved in, Vance. Thank you so much. We have time for a couple of questions. I think, Andy, let's start with you. And then Susan, let's go to you, Susan Demaro. So Andy, make sure to introduce yourself.
Sure. Hi, I'm Andy Imperato with Disability Rights California. I just want to acknowledge and thank Secretary Ghali, Governor Newsom, and all the folks who came together to make the announcement last Friday. But I do want to clarify the recommendations that came from all the disability representatives on the CVAC and lots of other folks around the state has not been to go with the CDC list. So I just want to correct, to the extent that Dr. Brooks thinks that we recommended that they use the CDC list to figure out who are the high-risk people with disabilities that should be prioritized. We did not recommend that. We recommended that the state prioritize regional center clients, IHSS recipients, and others who can show on an individual basis that they're at high risk of dying from COVID, which is a broad, diverse category. The CDC list was never intended to be used for this purpose, and we think it's a mistake to use it for this purpose. Thank you.
Thank you, Andy, for clarifying that. Susan, let's go to you.
Hi, this is Susan. This is Susan DeMorris with the Alzheimer's Association, and we're trying to pin down the current status of informal family caregivers. There are some articles out of San Diego that are reporting that family caregivers are eligible, and there are actually circumstances where the caregiver is eligible and the care recipient is not. And in looking at the guidance at CDPH, I don't see where that fits in the tiers as they exist currently. So I wonder if we have a response to that, or if I might be missing something.
Tomas, could you speak to Susan's question? I know a number of members of the CVAC have had this question over many meetings. Let's see if Tomas is still here.
Sorry about that. I was on mute.
Yeah,
yeah. Sorry about that.
Thank you. It's okay.
I know there was some confusion about that, and I know this was written down somewhere. We're gonna have to just track down what we wrote about this, because I know Erica did create some language to clarify this about family members who are caregivers and are and there is a verification process that they're an official caregiver, that they would be vaccinated. So we have to find that. I know that this was written down. I don't have it in front of me right now, but this is something we should follow up on.
Thank you.
We'll put it on the follow-up list and we'll make sure we find this before the next meeting. Let's go to David Lound, and that'll be the end of our questions because we're going to run out of time. So David, introduce yourself again.
Thanks, Bobby. So David Lound, California Association of Public Hospitals, Health Systems. Dr. Aragon, I've got a number of questions for you. So in this new
tiering, David, yes. You have to pick 2 questions because we're going to run out of time.
So difficult. Okay. First question, do we have total population numbers on this new tiering group?
We do. I don't have it I do not have it in front of me. I know that Erica, I know that we did calculations to get it get it down. I don't have it in front of me right now. Sorry.
Okay.
We'll get it. We'll get it for you.
Yeah.
After the meeting.
But that was part of the consideration.
Okay. I'll stick with pure number questions for my second one, which goes back to something I asked earlier. Given the feds noting that they are increasing allocations by 23% to states that they just announced yesterday, and previously the allocations to the state that CDPH on this call had said we're going to be increasing by about 20+% anyway. So, and your numbers show a 23% increase. I'm just trying to figure out, have you already included the 23% increase in allocation in the numbers you've shown, or is what the Fed's saying on top of that? How does that play out?
You know, that's a really that's a really good question, and I think we don't believe it until we see it. So when the number goes up, it's like yes, because in general it hasn't gone down, but when it goes up, yes. And then the other thing that happens is that there's other vaccines are coming to California that's not part of quote unquote our allocation, which is the FEMA and the pharmacy program. Back in Washington, when they're making these decisions, I don't know how they're thinking about it, right? From their perspective, they may just be thinking that this is total California's allocation. But so but in general, it has been increasing, and we anticipate, at least what we're getting assurances is that it will continue to increase. But until we actually we are seeing some of it because we are getting the FEMA. We are getting we are beginning to get the pharmacy, and then the quote unquote the dedicated allocation seems to be increasing. And just keep your fingers crossed that continues to go in that direction.
Great, thank
you.
I
do want to just sort of circle back on with working with the representatives that represent the disability group, and we are going to be working closely with a regional center and really making sure we reach out to people who are impacted by disabilities and helping us with that process of outreach, verification, and making sure that we reach the people who are in biggest need. So I do want to acknowledge Andy Imperato, who's been a key leader in that area.
And Tomas, if I may make a quick statement, Dr. Aragon, as related to disability, Down syndrome was listed by the CDC, but nothing that we showed the developmental disabilities was CDC. So that's what I mean by your input. You stated some specificities, and there's not a lot of specificity that Dr. Aragon had stated. We're working on that. We're working on the detail.
Yes.
We do know that this is an important group, and that is why that aspect of it is in the recommendations provided on February 12th.
Okay, thank you, everyone. Unfortunately, we've come to the end of our time together, and Dr. Burke-Harris is going to say a few words as we close the meeting.
Thank you so much, Bobby. And I want to quickly make a comment related to something that had several questions in the chat around whether the guidelines that were put out Friday now negate or supersede the guidelines that were put out before. And I just want to clarify that as the state has, so the statement that we made, which is consistent, that as the state moves from a sector and age-based strategy to a more age-based strategy. So when we complete tier 1 of phase 1B, right? So when we're done with phase 1, tier 1 of phase 1B, that's when we'll move to the more age-based strategy. And in part because of the input of this group and looking at the data, it was important to find a way to be responsive to those who are at high risk because of health conditions that put them at high risk of COVID, or disabilities that can put them at higher risk. And so we wanted to, it was important to be responsive to that. And so that was what was announced on Friday to begin on March 15th. But we are continuing to make our way through tier 1 of phase 1B, and then we will move to a more age-based implementation. So I just wanted to make sure to clarify that, because there were a few questions there. I want to thank all the members, all the folks who presented today. And I want to thank all of you, because the agenda for today and the invitation for all of these folks to come and present is really based, as I mentioned at the outset, on your questions. So having Secretary Richardson, having Eric and the team from My Turn, our wonderful teams in CDSS, in the governor's office, and in CDPH about our outreach and engagement. All of these different pieces are really in response to the questions and the concerns and the suggestions that you all are sharing. In today's meeting, some of the things that I heard and a few questions that didn't quite get answered, but we do plan to take it back, is this question of, for example, does the data, does the race and ethnicity data include the long-term care partnership? What is the role of Kaiser in the TPA? What's the difference between the CVS Rite Aid pharmacy partnership and the other part, the long-term care partnership? And a great question. So where should the public start? So if we are asking, if someone is trying to find their way to a vaccine, where do they start? Do they start with My Turn? Do they start with their doctor? Do they start with their county? And so all of these are really excellent questions. You have our continued commitment to try to bring you the best answers from all of our teams across the administration, our partners at the county level, at the community level, to be able to inform this process. I want to, again, today we had all except for 4 members attending. So thank you in our 10th meeting for continuing to make the time in your very busy schedules to improve California's vaccine distribution, allocation, and implementation process. Our next meeting will be on March 3rd. And we're going to be moving to 2-hour meetings. I know you all enjoy spending so much time with us, but we're going to be moving to 2-hour meetings. So the next 2 meetings will be March 3rd and March 17th, and they will be from 3 to 5 p.m. So there will be 1 hour shorter. And then following that, we hope to go to 1 meeting a month in April, May, and June. And with that, I want to thank you all again for your robust participation, for making this process better, and look forward to seeing you at the next meeting.
Thank you, everyone.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thanks.